Hello everyone. Hello and welcome to a very warm welcome to everyone who has joined. Today we will be starting a webinar which is on sickle cell disease awareness, and I am extremely grateful to all the chairpersons and panelists who have agreed to join this, and also all the participants who are interested. We hope that we would leave an impression on you with this webinar. So the design of this webinar is that we start with what sickle cell disease is and the pathophysiology and what we can look at it. And we scale it up to what happens during the prenatal diagnosis, what happens during a pregnant mother trying to give birth to the children who has sickle cell, and also the situation in the national policies, and also what is actually happening in the tribal areas. Sickle cell disease is a government initiative. Awareness is actually a government initiative where it has been said that for eradication, we need to have more screening, and for screening, we need awareness. Though we feel it is restricted to the tribal areas, but because everyone is moving everywhere around India, and there is intercaste marriages, there are marriages happening from every locations. So this disease is more in the cities as well. Hence, today I have a fantastic set of panelists and chairpersons, and without much delay, we will start the session. The first session would have Dr. Kanchan Mukherjee and Dr. Shankar De. Dr. Kushar sir, Dr. Kushar Gadil Ghosh will be joining later. But the session would be on the basics of sickle cell disease, current screening and diagnostic methods, and the narration would be delivered by Dr. Veronica Arora. I would introduce Dr. Kanchan Mukherjee as the chairperson. He is fetal medicine lead, Apollo Hospitals, Calcutta, Society for Fetal Medicine. He has been the national executive body member. He is immediate past president of our SFM Bengal chapter. He is faculty at various national and international conferences and has various peer-reviewed papers. So in all of this, sir is also an excellent leader for all of us in Bengal, and his advice is always there when we reach out to him. Welcome, sir. And we have Dr. Shankar De over here. He's a member of FOXY, ISOG, SFM. He's a practicing sonologist at Ultra Clinic, Fetal Medicine and Fertility Center, Asansol, West Bengal. He's the Secretary, Society of Fetal Medicine and Secretary, Asansol Obstetric and Gynecologic Society. He has a number of publications to his credit, and we all know him as one of the people who can pull out stunning images. Welcome, Dr. Shankar De sir, and welcome, Kanchan Mukherjee sir. I would please ask you to introduce our speaker, Dr. Veronica Arora.
Sorry to interrupt you, ma'am. Slides are not moving.
Okay.
Yeah, now.
And make it
Just
full screen.
do it. Yeah.
Can you see it?
Yes,
Yeah.
I can see it, but do it.
Can you make it full screen? Can you make it full screen, Stefan?
It is full screen. I'll try again. Is it visible now?
Yes, ma'am.
Yes.
So
Thank you. Thank you, Dr. Dipanjana, for introducing us in a nice way. And now we'll call Dr. Veronica Arora for her speech. She is a consultant clinical genetics, Sir Gangaram Hospital. She is MBBS, MS of Gene and DNB with super specialty in clinical genetics and gold medalist, awarded certification from European College of Medical Genetics. And she is also Secretary Delhi chapter, secretary of ISOPAR and head of North Zone Ispat Society also. And she is advisory board, Mayasati Society of India, member of MMID Initiative and DBT of Government of India. Published more than 60 papers and book chapters in national and international journals. And treasurer of Delhi SFM also, an executive member, Society of Indian Academy and Medical Genetics, and EC member, ISOBAB Delhi chapter. Also coordinator in FOXY, Focus Fetal Medicine and Genetics. And areas of interest are reproductive genetics, RPL, fetal malformation, autism, skeletal dysplasia, and many more. Thank you, Dr. Veronica, for joining us.
So much for introduction. And with the Panjana's permission, should I start the session?
Yes, ma'am, please. Thank you.
Thank you for having me here today. Thank you, the SFM chapter of Bengal, the Panjana, Sita ma'am, Ashok sir, and everyone. So we discuss an important genetic disorder today, and the relevance of this disorder is in the fact that we are already having gene therapy for this disorder, and we have multiple national policies that are being worked on even in our hospital, and the target is really now to move towards a treatment more than prevention, because more and more genetic disorders now have treatment. So let's now begin, and let's begin with the case. So, a 20-year-old male who reported a history of delayed puberty, decreased growth, severe joint pain, severe weakness in cuff, and there were past episodes of recurrent jaundice, severe body aches, and gallstones. So, we can see there is anemia, component of anemia and jaundice, suggestive of a hemolytic disorder. In his childhood, he frequently used to have fever, swelling of hands, and pain in chest, abdomen, etc. So we have a picture of recurrent infections involving maybe the bone marrow and jaundice and anemia. On examination, the child had a decreased growth, delayed signs of puberty, severely anemic phenotype, hepatosplenomegaly, spleen much larger than the liver, which again indicates a hemolytic state. The family history was positive, giving us a clue of a genetic disorder. And there was a similar kind of problem which was undiagnosed in his cousin at the age and who died at the age of 30 years, who used to receive frequent blood transfusion. When CBC was done and the CBC showed anemia, hemolytic anemia, and the hemoglobin was 8 with the retic count of 25%, which shows hemolysis and immature blood cells. The RBC showed, the WBCs almost showed a normal typical picture. So now in this lecture, we'd be discussing about in such a situation, which tests we will do and what is the most probable cause of patients having this phenotype and what complications may the patient have. How do we counsel these patients and how do we go ahead and prevent this disorder from happening again in the family? We will not be discussing thalassemia, but sticking to sickle cell anemia. So, sickle cell anemia is a disorder where we have anemia causing a lot of extramedullary hematopoiesis, where there is bossing, there is frontal bossing, there is hepatosplenomegaly, there is bone pain, and there are swollen tender joints which are present. On systemic examination, we can see that there is involvement of most of the systems. We start from top down. There is involvement of eyes causing a retinopathy. We can even check that in the carriers. Some carriers will have early ERG changes. So when you have a carrier, that is something that will help you diagnose it more confidently. Then we have cardiomegaly, cholelithiasis due to the hemolytic cells producing pigment. There is a bone marrow hypoplasia, the hypoplasia that is present. Bone marrow hyperplasia is present mostly due to anemia. So the bone marrow hypercompensates due to the anemia to make more and more RBCs, and these bones do become brittle and they are more prone to fractures. Due to an increase in the density of the sickled cells that are present, there is cerebral infarctions, multiple infections in the lungs, and the spleen finally gets so caught with the sickle cells that it undergoes a splenic atrophy and autosplenectomy. That disorder is quite common, and the majority of population of sickle cell anemia lives in the sub-Saharan Africa, and India is the second largest hub of patients with sickle cell disease after Africa, and overall prevalence of this disease is 4%, which is quite high. That is 1 in 25. So we can see that sickle cell anemia was first reported in 1910, and in 2023, we went on and got the gene therapy for the same disease. So now we have come a long way in treatment of this disorder. So now it is definitely an inherited disorder. It is a pure genetic disorder. It is caused by 2 mutations that are present in an individual in both copy of their genes. So it is an inherited form of anemia, a condition in which there aren't. So I thought my presentation is in the full slide mode. Is there a confusion about that?
It's all right.
Okay, yeah. It's an inherited form of anemia, condition in which then aren't enough healthy red blood cells to carry the adequate oxygen throughout our body. And normally the cells are in the shape of a sphere, but in sickle they become more of an S-shaped cells. They become rigid and sticky due to the excessive polymerization and are shaped like sickles or crescent moons. So what this looks like is a crescent moon. So these cells are shaped like moons or crescent moons. So they due to this shape mismatch, as you can see, they are irregular in shape and they can get stuck in small vessels. So in the large vessels, still they'll be okay to flow. So this is a normal blood flow that happens. And the spheroid cells would comfortably flow in the vessels as they are carrying a normal hemoglobin. But when these cells carry an abnormal hemoglobin, they form strands and they become aggregated together and they get stuck in the small vessels. Now these vessels get clogged and that area of the body becomes ischemic. So that ischemic area finally undergoes atrophy. There are cerebral infarctions. There are autosplenectomy. And basically due to the abnormality of the hemoglobin molecules that is present in the erythrocyte. This I just put for interest to show you how this was the report of the blood test on Walter Clement Noel dated on 31st December in 1904. So this here showed that he could see that the cells were sickled and he really said that they were very irregular but definitely did not really name the sickle cell. Here you can see this is how he made the cells and this is the original report just to generate our curiosity. So coming to the genetics of this disorder, I think the phenotypes is quite clear, and the genetics is that the change in the cell structure arises from the change in the hemoglobin molecule. Now, what really changes the hemoglobin molecule is that there is a single change in the amino acid that causes hemoglobin to aggregate. Let me elaborate. So, the hemoglobin molecule is a protein molecule, and we know that all proteins are made up of amino acids, and the amino acids are arranged in tandem, that is one after the other, and these amino acids needs to be in a particular sequence for normal functioning of that protein. So this is the partial DNA sequence of the globin chain, what I have shown here. This is what the normal amino acid sequence is. That is, we have a proline, then glutamine, then another glutamine. When a sickle cell anemia carrier or a affected individual is noted, and we do the genetic testing studies, we see that instead of the glutamine that should have been present in this molecule, it mutated into the valine amino acid. This sort of a change of one amino acid to another is known as a missense change, because one normal functioning amino acid gets changed into another. Now, this missense mutation causes an abnormality of the protein, because now the physiochemical properties of the proteins have changed. The normal functioning molecule functions in a different manner. And as you can see here, this is the normal molecule. And now in presence of a valine amino acid, it's a much larger molecule which keeps getting aggregated and forms sickle cell. So we just discussed that it's due to the missense mutation. So normally humans will have certain number of amino acid, and this is the structure of the glutamine, and it finally changes into a negatively charged valine. The mutant hemoglobin that is thus formed by the change of glutamine to valine polymerizes under low oxygen conditions. So especially when these people, even carriers of sickle cell anemia, go to an oxygen-less condition, like less oxygen condition, for example, a mountain, they stick together and they polymerize together and form bundles of long rods that are distorted into a classic sickle shaped. Sickle cells are stiff and sickle cells are sticky. So sickle, stiff and sticky is what we remember, and they tend to block the blood flow to the various organs and therefore cause pain and organ damage. So this just shows that this is a variant present on one of the chromosome 18. So again, if there is deoxygenation, there is polymerization, there is sickling of cells, and finally the cells break down and cause hemolysis. So we have two simultaneous processes happening. Number one is hemolysis due to the shape itself, and number two is the sticking of the cells to the blood vessels, causing the damage to the blood vessels, organ ischemia, and end organ damage finally. So now the inheritance, we've understood the genetics. It is called by a missense mutation. And that mutation always takes place at the 26th position of the hemoglobin molecule and changes glutamine to valine. Now the inheritance is like that of thalassemia. It is an autosomal recessive inheritance. That is, the parents will be carriers of the mutation. That is, one of their genes, a gene's copies or alleles, as we say, will be working and one will not be working. So the ones which will not be working are what makes them a carrier. And these people themselves will be okay throughout their lives, except when they visit a low oxygen condition where they may develop a crisis. If one parent has sickle cell trait and the other one does not carry the sickle cell hemoglobin, then as you can see here, in this case, this is a normal individual and this is the person with sickle cell trait. Then in this case, there is none of their individual will have sickle cell anemia, but you also need to check for the presence of beta thalassemia carrier state in this normal individual. And so when one person has a sickle cell trait, you need to do an HPLC of the other person to look for any presence of beta thalassemia minor or of sickle cell trait, because both these things will cause a 25% chance of having a transfusion dependent anemia. So sickle cell with sickle cell with hemoglobin E, sickle cell with a beta thalassemia minor, or will result in production of a transfusion dependent anemia, and we need to offer a prenatal diagnosis for the same as well. Now moving on, I hope this point is clear that if one person is a carrier of a sickle cell variant, You need to test the partner for not just sickle cell, but for hemoglobin E, hemoglobin D Punjab, and also for beta thalassemia minor. Once you have ruled out all these conditions in the partner by doing a simple HPLC, it's a great idea to then tell them that the risk is low. Otherwise, we need to offer a prenatal diagnosis. So here is a condition where one person has sickle cell anemia and one person is a carrier. So in this case, we can see that two people will have a sickle cell anemia, transfusion dependent anemia, and two will be sickle cell traits. So this we can make lots of combination and permutations, but we need to realize that there are two alleles and from coming from the parents, and one will go from the to the next generation, and depending on the normal and the sickled allele, we can predict the recurrence risk. So when the sickle cell hemoglobin gives up its oxygen to the tissue, the HbS sticks together and they form long rods. And the RBCs that contain HbS have a shorter lifespan. Thus, as we discussed, they develop hemolysis. And we have also discussed that a normal hemoglobin looks like this because the glutamine is much smaller, and the valine or the clumped hemoglobin which comes together looks like a more of a chain or a rod phenotype. Normal hemoglobin is shown on the left, and the mutated hemoglobin is shown here. So these patients who have sickle cell disease, they will present with anemia, and if untreated, they will die in the first 2 to 3 years of life. They will have episodes of pain because the vessels get clogged, enough blood does not reach an organ. So they will have something called a pain crisis, where the pain can also occur in the bones. And some people have milder episodes due to the presence of some modifying factors. They can have painful swelling of hands and feet, frequent infections. And these patients who have sickle cell anemia are frequently prescribed sickle cell vaccination and antibiotics to prevent life-threatening infections like pneumonia. Their growth is delayed. The vision problem especially includes damage to the retina. And the complications that should be looked for include stroke, acute chest syndrome, and pulmonary hypertension. Another important complication includes an organ damage. This organ damage could be to the kidney, liver, and spleen because the vessels get clogged. Sickle cell also block the tiny vessels that supply our retina and causes blindness, leg ulcers, and a less severe complication of gallstone. Diagnosis is simple by an HPLC that looks for the HbS peak. In heterozygotes or carriers, you will have a 40% HbS and 90% in affected individuals. The confirmatory test is by a targeted variant testing. You do not need to perform the laborious exome sequencing for this. You can just order that one targeted mutation where glutamine changes to valine, where you look for one single variant itself. So we do not need to, So we do not need to do the exome sequencing. You can do the Sanger sequencing or an ARMS PCR based test, which will take 2 days to come back. So diagnosis is actually pretty straightforward. As we discussed, it's a autosomal recessive disorder with a 25% chance of recurrence. The options for the next pregnancy include, like all recessive disorders, you do a prenatal diagnosis by either chorionic villus sampling at 11 weeks or an amniocentesis that is between 16 to 18 weeks. The chance of recurrence remains 25%. If a couple does not want to take that risk of prenatal diagnosis, you can go ahead and do an artificial reproductive technology. And now we have an IVF with pre-implantation genetic testing for monogenic disorders, where we can already test the embryo before it's being implanted and make sure that the cell or the embryo does not have the sickle cell mutation before we implant it, and get a good and fairly accurate result for the same. So I will just quickly, like in 2 minutes take you over the treatment modalities that are now available, because we cannot all the time go ahead and offer a prenatal diagnosis, and there are children who undergo this disorder and we have to treat them. So we have, the treatment is basically targeted at avoiding the different crises, the pain crisis, for example, and babies and children under 2 years of age should make definite frequent visits to the doctor, get their vaccinations, and whenever there is anemia, they must be given blood transfusion and all the medicines to reduce the pain and prevent complications. Antibiotics, children with sickle cell anemia have to begin the penicillin prophylaxis to prevent severe infection. As an adult, if the spleen is not autosplenectomized, that can be removed. Important are the pain reducing medication and a medicine called hydroxyurea, which reduces the frequency of the problems of the pain crisis that is present, because it seems to work by stimulating the production of the fetal hemoglobin, which replaces the sickle cell hemoglobin. We give vaccination, prevent stroke risk, give blood transfusion, and an important drug to be given is a nitric oxide, which dilates the vessels so that the vessels are not blocked by the sickle cell. Bone marrow transplantation, a great option, but of course it is usually reserved for people younger than 16 years, because the risks increase for people older than 16 years in the donor. But of course the big challenge remains how to find a donor, because we need a haploidentical donor for the same also. We have newer genetic therapies, newer immunological therapies in sickle cell disease, including hydroxyurea, crisanulib, voxetilor, and L-glutamine, but they are still really being studied, and they act at three important places in sickle cell disease: at the level of sickling, at the level of hemolysis by decreasing the reactive oxygen species, and at the level that they become clumped and aggregated, so that the cellular adhesion is decreased and they don't stick to each other. So this vicious cycle of polymerization, hemolysis, and vaso-occlusive process is then targeted by all the drugs that have been mentioned here, including hydroxyurea and the modulator of hemoglobin oxygen affinity. As I said, that in oxygen low areas, these cell will sickle. So a HOPE trial was done to really try and see that if the oxygen affinity can be increased for these cells. And we have other drugs which will decrease the hemolysis, like pyruvate kinase activators. So, of course, the great news remains that we have a gene therapy that will increase the hemoglobin F, that is the fetal hemoglobin, and prevent sickling. And it was recently approved on December 8th by the FDA to treat patients with sickle cell diseases. And now we have lots of trials going on for the same. And in India, we are now coming on to build the stem cell transplantation as well as the gene therapy program by the CSCR. So with that, I like to end my presentation, and definitely like to bring on the fact that we all know that this disorder should be prevented by prenatal diagnosis. But if we have a child with sickle cell anemia, all hope is not lost. We have many questions which will now be answered in India, and there are multiple government policies being instituted for the same. And especially the National Sickle Cell Mission is working on the same. So with that, we all pray towards a sickle cell free society. And I thank you and extend my gratitude again to all for this opportunity.
Thank you, Veronica, for that very lucid presentation. And the special thing about you is you speak a language which we all understand. And every time I hear you, I second that, and I just think that it is very true. You have set the tone of the entire evening at the right level. So I now pass on to Dipanjana and tell all the audience that if you have any questions, please post them in our chat box and we will deal with them towards the end of this meeting. Or you may as well post your query. I mean, we may as well, might as well post our answers there. Okay,
Thank you.
right. So over to
Yeah.
Dipanjana.
Thank you. Thank you, Kanchan. I'm Sakruti here. It was a lovely presentation indeed. If you allow, I can ask, yeah, really, really excellent work. Now, I have a question, Veronica, for you. Hello, can I ask?
Yes, please, sir.
Yeah,
Please.
yeah. Is that we see cases where one partner is a sickle cell carrier and the other one is beta carrier.
Yes, sir.
And in those cases, what we normally do is HBB gene sequencing trial.
Okay.
Is that the correct approach or not?
Yes, sir, you're doing it. It's absolutely correct.
But you did say something about doing a point mutation study in sickle cell only
Okay.
and
So,
not going for the entire gene sequencing.
yes,
In
sir.
that
So
case, how to go about it?
that is also fine. So there is something known as an ARMS PCR. It will give us a result in 2 days. So sickle cell anemia is only caused by one mutation. So you don't need to do whole HBB gene sequencing for the same. So for sickle cell anemia carrier, we can just order that one selected mutation. And for the person with beta thalassemia, for them, we can do a more extensive test, that is HBB gene sequencing. So once the laboratory has identified these mutations, they can check it on the fetal DNA. So this is what, and if you have carriers, both parents carriers of sickle cell anemia, then it's very straightforward. We can do a PCR for both of them and save a lot of money like that.
Right, right. Now, what about sickle cell carrier and E-trait? What should we do about them? Should we do invasive or not?
So HbE and S again is in most of the cases a transfusion dependent anemia, E and S. So sickle cell with E and even E, even most is a transfusion dependent anemia. Hemoglobin E is again one single mutation. It does not require HBB gene sequencing. So if we are confident it's hemoglobin E on our HPLC, then we can go ahead and do a targeted variant. But that being said, there are three peaks which elude with hemoglobin E. That is hemoglobin Lepore, E, and D run. So in case of hemoglobin E, we are actually less sure that which is the mutation. So for hemoglobin E as well, we do a HBB gene sequencing. And for HBS, we do the ARMS PCR. But in both these cases, we do a invasive testing.
Thank you. Thank you.
Thank you. Thank you, sir.
Thank you so much, and such a nice
Yes.
discussion. I guess
Great
it
presentation.
helps a lot of people. So we move on to our second session, which is also equally alluring. I thank my chairpersons, Dr. Kanchan Mukherjee and Dr. Shankar De. Thank you, sir. And thank you, Dr. Veronica, for yet another crisp and beautiful, lucid presentation. Always a pleasure to hear you. So our next sessions would be, we move on to our session 2, which is basically, just allow me a minute. Yeah. So this session would be chaired by Dr. Preeti Dubey ma'am and Dr. Ojaswini and Dr. Kusharadi Ghosh sir. So this particular session is on the national policy for eradication of sickle cell disease, giving the global and Indian perspective. And this talk will be delivered by Dr. Deepa Bhatt. I introduced Professor Kushargadi Ghosh, sir. In one word, he's a mentor of many, but he's a director, Institute of Fetal Medicine, Calcutta, consultant, OB-GYN, Woodlands, and Newtia Hospitals, Calcutta. He's an examiner in MBBS, MD, and final MRCOG exams. He has a lot of accolades to his cap, so I will not go through each of them. But the best thing is, sir, is always learning, always asking questions, and that's something which is fascinating. Our second co-chair would be Dr. Preeti Dubey, ma'am. She's a founder secretary SFM Orissa chapter. Again, she is a mentor to many. She's an executive member of SFM. She's in the core committee of various projects in the National Health Mission and the director of Family Welfare Orissa. Again, she has a lot of accolades and feathers to her cap. I'll not go through all of them in respect of time. I request you to please introduce our next speaker. Sorry, Dr. Deepa Bhatt, ma'am. Is the slides visible?
Yes, it's visible.
Okay, thank you.
Sir, you are doing, or should I go ahead? Sir, Radhi sir, can you hear me? Can you hear me?
I can hear you, but I think sir is offline.
Your voice is echoing actually. Are you on two devices?
Is sir there? Dr. Ghosh, are you there?
Sir has left.
Can I have
Okay,
that
okay.
CV?
Yes, ma'am. I'll just put it up. There you go.
Thank you, Dipanjana. Thank you, SFM Bengal, for this opportunity. So it is my privilege to introduce Dr. Deepa Bhatt. She has 43 number of publications to her credit. Professor of Anatomy and Level 2 BGCI Certified Genetic Counselor in JSS Medical College and Hospital, Mysore. Her research trust areas are rare diseases and hemoglobinopathies, and she is a part of ICMR National Task Force on Sickle Cell Disease. So over to you, Dr. Deepa.
Yeah, good evening all. Thank you SFM Bengal and Dipanjana for this wonderful opportunity. So I shall share my screen.
I just also need to say one good word over here. So Dr. Deepa Bhatt has been a great friend, and she also, in any hemoglobinopathies, if I have a doubt, I ask her, and it's my opportunity to thank her and be grateful to it. Thank you, Dr. Deepa.
Thank you, Dipanjana. So to begin with, so this is the overview of my session. So in 2020, it's not that the sickle cell disease was not existing, but in 2023, there was an announcement in the budget that this a lot of budget was allocated to this specific disease, that is sickle cell disease, was announced by Nirmala Sitharaman, then the finance minister, which further led to the launch of the National Sickle Cell. Initially, it was coined as eradication, but later it was changed as an elimination mission. 1st July on Doctors' Day in 2023 in Shahdol district of Madhya Pradesh. This was launched as a mission mode, and at the same time, parallelly in several states across the country, this has been started. So why was this disease chosen as a national program was that this was considered as a disease of public health importance, and it could be recognized in a latent or a preclinical stage itself. And we are very clear of its natural history, and the prevalence is also very high and the disease is very clearly defined. And with considering the test, simple low-cost tests are available and the cutoff levels are very much defined. So considering this was taken into a national program. So why parallelly it's important? Its implications. So the person having sickle cell disease undergoes, as the previous Veronica ma'am mentioned, the clinical manifestations are seen as a vaso-occlusive crisis. The term itself says the blood vessels are occluded by the sickled RBCs, leading into the manifestations depending on the organ which it has impacted. This could be a subclinical, or even there would be clinical manifestations. Slow ongoing process leads to a lot of end organ damage. It's not that there is a specific symptom by which we can directly diagnose. They could come in initial stages just with recurrent fever, There could be pain, there could be a chronic pain and acute on chronic. So many more symptoms. It's a general symptom with anybody could present with. And also there are repeated hospitalizations, some of them requiring blood transfusions, and there is a need for advanced tertiary care is essential here, and there is a need for a hierarchical referral system. That's from the health perspective. Coming to social, so it leads to a lot of mental health issues, psychosocial problems, because it's a lifetime disease. Once it's diagnosed, though the gene therapy advancements has reached India, a lot of medications, clinical trials are there. Considering the disease burden in the country, still we have long way to go to reach every corner and at the grassroots level. So the mental health implications of this disease is tremendous. Now, because of sudden surge in the screening, we are observing a lot of factors leading to stigmatization. Many people, though they know that they are a carrier or they are affected, they are not ready to openly discuss about their disease in the community. This has led to a lot of school as well as work absenteeism, either due to the ill health or attending your own ward to attend the hospital. And also the education level about the sickle cell disease in the community is at very low, and it leads to a lot of family implications. Other than that, a lot of economic implications too, in terms of direct costs due to admissions or disease related expenditure, indirect cost to the family members, and out of pocket expenditures. So these are the implications. So coming to the global scenario, you can see that it is seen across the globe, and initially it was in the malaria prevalent region. This was a genetic advantage for those people living in the malaria prevalent region, where sickling will reduce the intensity of the severity of malaria. But this theory no more is holding, because the gene pool has already disseminated across the globe, and more seen. As you can see, the first is in sub-Saharan Africa, followed by India. India stands second in the globe. Spanish speaking regions in South America, Caribbean, Central America, Saudi Arabia, Mediterranean countries, Malay archipelago, and also the Australia. The colors in this particular picture indicates the darker one has some of these countries where the prevalence is more. So as Dr. Veronica said, initially in 1870 itself, so the local African literature said, Obanges means the children who come and go. They felt that there are more underprivileged children who are born, they have a disease, and they die soon. So this was used, but only it came into existence when the Noel, who was a dentist, who was from West Indies, in a Chicago hospital, he came with a history of, there was a muscular rheumatism. The term used was muscular rheumatism and bilious attacks. He visited a then cardiologist and a physician, Dr. Herrick, who referred him to Irons, Dr. Irons, who was an intern. As shown in the previous speaker, the prescription where he observed that there was an abnormal cell which had a shape of a sickle. So it was still not coined as anemia, but he succumbed to this disease in 1916 itself due to pneumonia, recurrent attacks of pneumonia. And later date, in 1920, the Dr. Mason, he coined it as a sickle cell disease. So coming to the American picture, here almost more than 1 lakh are affected by sickle cell disease, and 90% of them belong to African American lineage, and 3 to 9% are Hispanic or Latino, and 1 in 365 birth, 1 in 365, which is significant. The Africans have this condition, and 1 in 16,300. And coming to the carrier, as mentioned, plays a very important role in carrying this disease further down the generation. It is 1 in 13, which happens to be a significant number. So coming to the Africa, where even in terms of disease severity as well as the the prevalence is very high. You can see here the Nigeria, the Cameroon, then Gabon, then Ghana, Kenya, Uganda, Malawi, the Republic of Congo. These are the different the regions where this particular disease is highly prevalent, and we observe that under 5 mortality is very high in this, and also the severity of infections, crisis, and the death due to that is commonly seen in African context. So let's come to India. How India is something which is challenging, as we all know that the culturally is very diverse. The gene in India is across India in different places. The same disease comes with different, the phenotype diversity is seen. So though India is second, here though the current national program has prioritized the tribal region, but we equally have tribal and non-tribal, and our current experience and observation, the non-tribal community has much more severe phenotype compared to the tribal. Then what the prevalence, what the different papers or the publications say just denotes a tip of iceberg. We have long way to go to understand the exact prevalence of this particular disease in India and phenotype diversity. I work in Karnataka, where it's away from the Tropic of Cancer, where it's mild to moderate. When we come to Gujarat, Madhya Pradesh, Orissa, the severity is very high. So this, though it is a point mutation, as mentioned earlier, just change in one alphabet is leading to this disease, but so much difference range. We get people, the patients who are having exclusive pain crisis, and some of them at the other end of the spectrum is a hemolytic crisis. So we have a combination of these manifestations, which makes it very difficult in initial years to identify, so that long time goes in diagnosis, forget about the initial precautionary measures and the management. Now, add on to the challenge as mentioned, different parts of India have different combination variants of abnormal hemoglobin. I'll mention the significance of this variant when I speak about the elimination mission. So if we go to as mentioned, there could be a sickle E variant, sickle D, sickle Tal, sickle Punjab, and many such combinations are there in different geographical locations of India. And add on to this, this is the first disease which is genetic etiology, which has been taken into mission mode. So we have tuberculosis, HIV, malaria, and different diseases, which are all infectious or a non-communicable disease. But this is a first genetic disease. So there are a lot of challenges, because now it's just 1 year old program. The entire government system is confused how to take in a disease which is genetic, and they continue to treat it as other national programs, which is another challenge which is seen as a ground reality. And one more, as I mentioned, the program is still in a very nascent stage, though very well designed, and operational guidelines are very well made, but execution at different cadres of health system are still a very great challenge. So you can see different publications say that different regions where it is existing, Karnataka, Tamil Nadu, Andhra Pradesh, Orissa, even the Jharkhand, the northern states of India. So the frequency of this beta S allele is varying, the clusters you can see. And one more, I can show that, see the different publications like Karnataka is left out because this was not considered at all, though the percentage is 0.8% is a SS rate and almost 12% is a AS rate in Karnataka. So different publication, though they give the numbers, it may not actually represent. So the previous one, this publication was taken only based on HPLC, but many more tests are utilized currently for a screening program which has been left out here. So this is the current dashboard, the National Sickle Cell Portal, which is existing. You can see currently 4,29 lakhs people are already being screened in that. The carriers are almost 11 lakh 62,000 and 1 lakh 66 is confirmed cases. Can you imagine the burden now? So how many people are going to cater? How many people will be getting gene therapy? Essential And we are at a stage, the basic drug, the hydroxyurea, is now reaching the 1 year is the state at which the national program exists, and just now this specific drug has reached this population. And what are the challenges in these tribal areas would be dealt by Dr. Kolkande sir. So continuing to the programs across different countries, United States already has a well-defined national sickle cell disease program, and also there is a disease treatment demonstration programs which is well defined and executed well, and now they have shifted to the newborn screening programs and also offering all the required prenatal, preconception and premarital screening as well. And in UK, NHS offers sickle cell combined with thalassemia screening program and an NGO, the Society Sickle Cell, which assist along with the national program. And in Nigeria too, there is a government-led program. Brazil too, the public health system has. There is a government-led and also an NGO-led program. The GASCO, that is the Global Alliance for Sickle Cell Disease, from the patient perspective, patient advocacy group, has several chapters across different countries. For example, India has NASCO, it's a national alliance. So the National Sickle Cell Anemia Elimination Mission, which was officially launched in 1st July, and it was executed from 1st October across India. So this is a portal which you can see very well, all the user manual, the current day-to-day screening numbers, and for different levels, for ASHA workers, what is a laboratory diagnosis, what are the treatment guidelines, what are the education materials, what are the even counseling modules, everything is available in a downloadable PDF format if you visit this particular portal, which is a combined effort of the Ministry of Health and Family Welfare and Ministry of Tribal Affairs, that is MOTA. So moving on. So as I mentioned, the goal was to eliminate this as a public health problem before 2047. So we all have to gather. It's not a one-person approach. It's a comprehensive approach, starting from a primary care physician till the medical geneticist, fetal medicine, everyone, and even including a public health expert who has to play individually an important role towards this particular elimination. So how this elimination mission has been planned is that initially they have concentrated only on high prevalence states, that is to cover 7 crore in 3 years. Now the target is led only for 3 years, and 17 states has been chosen for the first level screening, which includes even West Bengal. The states are mentioned there: Madhya Pradesh, Kerala, Uttar Pradesh. The remaining places as well, and here it concentrates first initially on primitive vulnerable tribal groups, then tribal community and the ST population, followed by targeted approach for screening has been adapted for non-tribal districts based on the facility based to all antenatal mothers in first trimester at the primary healthcare facilities across the state. So they have ensured that there is no parallel system. Already existing National Health Mission NHM activities with existing, no additional staff has been provided. Whoever are already existing, they are given an additional resources to avoid duplication of the efforts. And these two, Health and Family Welfare and Tribal Welfare Affairs, together with RBSK, Pradhan Mantri Surakshit Matritva Abhiyan and Anemia Mukt Bharat, they have leveraged through this to execute this particular mission. So what are the priority areas? So without awareness, that's it would be really challenging to complete the screening of entire population. They have been really working hard to increase the awareness through several activities. The mass screening has started in a mission mode. Everyday targets are tremendous. Almost in every district, they have given a target of nearly 300 to 500 has been given. Every day they have to, a robust system of monitoring also exists here. Both the diagnostic and therapeutic care has been planned in this national guidelines. Monitoring system, as I mentioned, and they have been really working hard to strengthen the capacity of primary healthcare. The reason being, most of them are the tribal and low socioeconomic status communities who are hard to reach geographical location. So they hardly come to a tertiary care setup seeking healthcare. So the plan is to establish a referral system so that the mild to moderate cases are filtered at this level, and then those who require crisis management and a tertiary care or an advanced therapeutic care, including prenatal diagnostic facilities, are offered at a tertiary care. And capacity building, probably during our medical days, sickle cell disease should have been just one sentence somewhere in the corner of some of the chapters. But now even medical council has made one chapter mandatory in across different subjects. So and also they have planned for several tier capacity building programs for the primary, secondary, and tertiary care teams, and also to bring a cost efficient intensive intervention at these high care facilities. So how they have divided this? They have divided it as 3 pillars. So the 3 pillars are primary, secondary, and a holistic care. So in the primary prevention is the genetics. So how? The number 1 is they should themselves voluntarily, they should seek for prenatal diagnosis. So for which awareness is essential, especially premarital and preconceptional. Genetic counseling and testing facilities are provided, and involvement of the community has been found to be very important so that they take the onus as well as responsibility for their own community health issue. So coming to the secondary, where screening and detection of all the traits. So under 40, 0 to 40 is the target now, followed by a cascade screening. If any family member is affected or a carrier, entire family will be screened for the sickle cell presence of the either a carrier, AS, or a SS. Even antenatal screening is offered. And for a early detection, the newborn screening is also being offered so that the early diagnosis and timely preventive measures and also the management would reduce the morbidity as well as the mortality related to sickle cell disease. And also, they also require a lifelong follow-up and care, either in terms of investigation as well as a clinical monitoring. So this is also offered under the second strategic pillar, that is secondary prevention and the screening. The third and an important is, as I mentioned, it requires a holistic care where every cadre has been trained and there is a need for management option. Now the hydroxyurea is available at PHC levels only, but the doctor should know how to dispense it, how to monitor post for the adverse reaction, when to prescribe, when to stop it, when to refer. So everything has been covered in the guidelines. And also advanced diagnostic treatment in terms of the requirement for a genetic diagnosis as well as prenatal diagnosis at a tertiary healthcare facilities, requirement for a telemedicine, all are very well defined in the national guidelines. There is an add-on component of Ayush system and community adoption, patient advocacy groups, and lifelong care, including disability. They come under a 40% disability and they are given 50% concession in their travel in railways as well as a bus transport, and they are provided some kind of facilities towards education. So, and they have to be regularly evaluated. They are given a card which identifies them and helps them with all the disability benefits. So what are the services offered? Now under the program, at the field level, at the PHC or at the health and wellness, Ayushman Arogya Mandirs, the screening is happening. So the screening is by, some of the states have initially tried with solubility test, which is a screening test. If it comes positive, solubility as mentioned earlier, it is the altered hemoglobin which precipitates and it produces a turbid when it is put into a solution. So that is recognized by putting lines behind. So that is used as a screening test. Solubility, which is a very cost effective, less than 10 rupees test, has been utilized. But under the national program, considering that pricking them twice would be difficult. Now, directly the point of care testing options, POC tests are available, where lateral flow immunoassay mechanism has been used. It is almost, you can see here in this picture, this is almost comes like a UPT kind of kit. A buffer will be available. 20 microliters of blood is put into the that buffer, and it's put into the well. Within 3 minutes, you can very well see the lines which indicate either the person is a normal carrier or affected. So once the guideline says that if a person comes positive in the screening test, this is still, POC is still considered as a screening test. If the person is positive here, they have to be, the blood is taken to district hospitals where the facility for hemoglobin electrophoresis, which you can see here, is available, and initiation of the treatment is only very clearly it says you can start treatment only if HPLC says it is positive. And still we are in the phase where government hospitals, this week there is a call for establishing center of excellence across all these 17 states, where the facilities would be provided for a genetic testing as well as a prenatal diagnosis. As of now, the public-private partnership, wherever the facilities are available, is being utilized. So other than that, there is a national registry. Every CHOs, community health officers, will download an app in which everyday screening will be entered there. Confirmatory test, hydroxyurea dispensing, disability card issues, everything will be available in the national portal, which is available in Android-based app in their own mobiles, which is monitored by National Informatics Center. The hydroxyurea is dispensed and monitoring with the routine investigation with CBC, RFT, LFT, and other advanced investigations are also considered. And a technical team across the state. I am a member of a Karnataka Sickle Cell Expert Group. Similarly, every level, district level, state level, the technical group is formed who will be continually helping the team to execute and deliver and implement this national program. A lot of education activities are being delivered for different people. This is up to what I have put in blue is currently happening. The disease management has started, but we are still in a stage. Not every person is getting a complete treatment in terms of his symptoms, and also availability of tertiary care benefits for them. So even the capacity building of different level doctors are yet to happen, and also the genetic counseling and advanced diagnosis, and also in terms of the advanced therapy. So we are still moving from screening. Screening is happening very robust, but the rest of them requires a collective efforts. So I would really appreciate SFM for taking such a hot topic, which is a need of our as one of our webinars, so that this would really be addressing, indirectly you are addressing one of the need of the National Sickle Cell Elimination Mission. So one more challenge, a word of caution we are discussing here. Biggest challenge we are facing in the field is this test, what I mentioned, is designed in such a way that it detects only one disease, that is sickle. Variants are missed because one is sickle, the other we don't know it is A. It comes as A, but it could be THAL, it could be E variant, D variant, but all those people will come as a carrier in this point of care testing. So as a tertiary care practitioners, you should be really careful to ask for manifestations, so that if there is always a strong index of suspicion, please go for a genetic testing, and also as mentioned, either a targeted gene approach or a complete HBB testing itself. So you can see here, the severity varies: SS, S beta thal, SO Arab, SD, that is Punjab, and many more. We have seen all variants, more from Assamese side, E variant, towards Gujarat and the northern region, the Punjab variant. Sickle thal is present everywhere. So the severity varies. So most of them has to be treated both like the thal, other variant of For example, sickle cell would require transfusion. At the same time, hydroxyurea therapy many times would reduce the need for number of transfusions. So index of suspicion, suppose there is a person who is screened in the national program, found to be carrier but symptomatic, should be a concern for all the attending experts. So my take home message is that as a part from the fetal medicine point of view, to ensure that every antenatal mother has to undergo, it should become a habit that have you undergone a sickle cell screening. Second thing is, my kind request is that in my state, there is no fetal medicine expert from the government who can do the CVS or amniocentesis, and they have to go a private facility where they have to undergo this. So as a national chapter, a request is that every state should have some mechanism where this facility, see, until unless we give an answer for a couple who come to seeking that, can you help me with this pregnancy to understand the affected status? So very much initiating it as a national program would definitely go wasted. So it should be the geneticists, the fetal medicine, public health expert, everybody from their own society should contribute from whatever the segment of the national program they need to execute as the expert. So as a continued, definitely 2047 elimination is not totally possible, but reducing it as a public health problem would be a dream which we can really achieve if we add on antenatal screening with the newborn screening for those missed out cases. As I mentioned, a request is to represent from the SFM so that it's not the states which are active. My request is to every district, because Karnataka is a big state with 31 districts. A person has to travel almost 12 to 16 hours to reach an apex center, which is in Bangalore. So the provision should be at every district, at least a collaboration. Gujarat is doing a very good job where a fetal medicine person is brought by the government to the district hospital setup, which is identified by the peripheral healthcare system, educated, and that coordination is running very well. Almost Gujarat state is very ahead of sickle cell programs executed through the state government. So it would be a dream come true if the similar system comes across not only the 17 states, across India. So with this, so this was a national expert team who has gathered together across India to work for a better sickle-free society in India tomorrow. Again, I thank SFM Bengal and Dipanjana for giving this wonderful opportunity, and also thanks a lot for taking such an important topic. Thank you.
Thank you, Dr. Deepa, for that elaborate presentation. It was really very nice.
Thank you.
Over to you, Dipanjana.
Thank you so much, ma'am. I do thank my chairpersons, Dr. Preeti Dubey, ma'am, and Dr. Kushaga Digos, sir. And of course, Deepa, thank you so much for such an elaborate and beautiful presentation. It was almost as if, we were getting to know so much more than we know. So thank you so much for such a detailed presentation. We will have a trade partner video right now before we move on to our session 3. Thank you. Thank you. We move on to our next session, our session 3. Our session 3 would be on the reproductive health, pregnancy, and sickle cell disease. I invite my chairpersons, Dr. Sita Ramamurthy Pal ma'am and Dr. Gayatri Desai ma'am, to please chair this particular session, which will be delivered by Dr. Jaya Chawla. Dr. Sita Ramamurthy Pal ma'am is a consultant fetal medicine and obstetrics, Apollo Multi-Speciality Hospital, Ankuran IVF and Fetal Medicine Center, and at Institute of Fetal Medicine, Kolkata. She is the honorary treasurer, Bengal Obs Gynae Society 2020 2023 to 2024. She's the chairperson, Genetics and Fetal Medicine Committee, FOGSI 2023 to 2025. She's the president, Society for Fetal Medicine, Kolkata chapter 2024 to 2026. And obviously she's... yes, ma'am. So she does have a number of accolades also to her name. And we also have Dr. Gayatri Desai, ma'am. She is a diplomat of American Board of Obs-Gynae. She's a medical director, Kasturba Hospital, Seva Rural. She has numerous papers to her name, and she has special interest and experience in rural and tribal health. Welcome, Dr. Sita Ramapurthy Pal, ma'am, and Dr. Gayatri Desai, ma'am. And may I please invite both of you to introduce our speaker, Dr. Jaya Chawla.
Thank you, Dipanjana. I take this opportunity to firstly thank the SSM leadership, Dr. Shukran sir, and Dr. who have taken this important topic for our chapter to have this webinar, and Dr. Dipanjana for coordinating so well. And thank you, Dr. Deepa, for an excellent talk. It just shows us how government has taken so much of initiative, and we are going in the right direction. So our next talk is by Dr. Jaya Chawla, and it's my pleasure and honor to introduce and invite her, a very active member of our Committee of Genetics and Fetal Medicine Committee, FOGSI, Joint Secretary of the Society of Fetal Medicine Delhi chapter, also an executive member of Fetal Medicine and Genetics Committee of AOGD, executive member of the Safe Motherhood Committee of AOGD, and also of the Society of Fetal Medicine. She has been the executive committee member earlier, and of the multidisciplinary committee AOGD. She has a lot of...
You know me, and that is my intro.
She's a very, very enthusiastic member with a lot of bubbling ideas and activities, a great speaker, a great writer as well. And over to you, Dr. Jaya, for taking the reproductive aspects of patients who have this disease and how we can treat them and take them forward in pregnancy. Thank you. Over to you. Thank you.
Thank you so much, ma'am. Thank you, Bengal chapter. Sita ma'am, thank you yet again as President Bengal chapter, and Dr. Dipanjana for having me here. I seek your kind permission to share screen, please.
Yes, ma'am.
So is that visible?
Yes, ma'am. Please make it full screen.
Yeah. Is it better now? Yeah.
Yes, ma'am. Thank you.
So, great. So I also like to say good evening to Ma'am Gayatri Desai, one of my inspirations for sickle cell disease by now. So reproductive health, pregnancy, and sickle cell disease, that's the topic assigned to me. And I would skip the background because it has so beautifully been highlighted by my previous speakers, Dr. Veronica and Dr. Deepa both. The clinical implications also have been discussed in detail earlier, but briefly speaking, it affects pretty much every part of the body, including the neurocognitive function, including causing meningitis and stroke, which is a real risk for us, including causing hyperbilirubinemia and hepatopathy. It includes gallstones, it includes papillary necrosis of the kidneys, it includes albuminuria, a major cause of concern to gynecologists and obstetricians. It causes delayed puberty. It causes avascular necrosis of the femoral neck. It causes bone marrow infarctions, retinopathy, glaucoma, pulmonary hypertension, which is a grave disorder for us in pregnancy, acute chest syndrome, another challenge in pregnancy, acute pain events, cardiomegaly and diastolic heart failure, anemia and leukocytosis, septicemia, some of these being prognostic factors in pregnancy, splenic infarction, skin ulcers, and chronic pain, to say the least. Now, why at all such a deadly disorder has affected humankind? The reason being this, that if you look at the map on the top, you would realize that this is the distribution of sickle cell across the world. And then lower down, we see that this is the profile of malaria endemicity across the planet. And we realize that they have a mirror image in common. And that is the reason why actually malaria people have a survival advantage when they have sickle cells. And that is the reason why these are endemic in common parts of the world. When we look at a map of India, we realize that there's a belt, the central India, and the tribal population is mainly affected, be it Odisha or Maharashtra, Gujarat, Rajasthan, and Madhya Pradesh. So coming to reproductive health, my first aspect. When we look at these studies, we realize that puberty, the Tanner stage, stage 3 precisely, there is a lag in age when cases of sickle cell disease acquire their Tanner stage 3, and it is significantly different. When we come across the same centiles on this side, we realize that the estradiol levels are different. And that is why chronic hypoxia, vaso-occlusive crisis lead to pituitary and gonadal hypoplasia. Multiple transfusions and iron overload cause gonadotoxicity. These are coupled together with micronutrient deficiency in tribal areas, especially zinc deficiency has come to the fore. And coupled to that lower BMI, we realize that girls with sickle cell disease have a delayed puberty. Dysmenorrhea. This particular study of women with a median age of 16 years tells us that the prevalence of heavy menstrual bleeding is increased to the tune of about 29%, and dysmenorrhea, moderate to severe, causing loss of quality of life, is to the tune of 61%. So girls with sickle cell disease have a significantly more dysmenorrhea and heavy menstrual bleeding. Coming to the fertile window, sickle cell disease affected women have a narrower fertile window. When I say that, they have delayed puberty, we have discussed. So their menses begin late, but their menopause occurs sooner. So their optimum fertility levels are actually a narrower bit of window. And talking of today's times when we deal with all kinds of advanced maternal age conceptions, these women do not get such chance. When we look at the AMH levels in the sickle cell disease, we realize that when we look at the negligible to the reduced levels of AMH, the red bars, the sickle cell disease bars predominate. And when we come to high AMH levels, it is the non-sickle cell ones that predominate, suggesting that women with sickle cell disease have diminished ovarian reserve. Why so? Number one, we do not have the same type of care across all parts of the world, and therefore poorly treated sickle cell disease is a risk factor here. Then comes incidence of hemolysis and anemia, episodes of vaso-occlusion which affect the ovary adversely, hypoxemia and ischemia caused to the ovary, hypermetabolic state, nutritional deficiencies, endocrine dysfunction, and iron overload. Until then, so far, so plausible. But not only the disease, but also therapy in terms of multiple transfusions and hydroxyurea tend to impact the ovary negatively, causing cytotoxicity and contributing their part to this jigsaw. Is hydroxyurea really responsible? You would be asking me. Even I was surprised. But when you look at this cohort by age, you realize that the AMH levels are lower to the tune of 26 to 38 here. And it is significantly so. The FSH has started rising at about the age of 30. And this is clinically significant. But when you come here to the subgroup taking hydroxyurea, you realize that these changes are more pronounced vis-a-vis these changes of age-related decline in the hydroxyurea group. There is more to it. There are numerous studies placed there down there to suggest that the women taking this hydroxyurea, those not taking, this is the AMH level. Those taking, the AMH level is here. And this is obviously statistically significant. Hydroxyurea is associated with lower AMH levels in French adults, and it is associated with earlier menopause to the tune of about 5 years or so. What is the mechanism of infertility? The mechanism here is that when hydroxyurea is given as a part of chemotherapy to these individuals, it causes DNA double-stranded breaks. Some of these breaks get auto-corrected. DNA repair succeeds in correcting them, and we have a follicle survival. But if the DNA repair fails to occur, then we have apoptotic death, and we know girls have a finite set of follicle reserve. So when that goes apoptotic, then chemotherapy accelerates the age-related decline in follicle reserve, and typical protocols result in loss of 10 years of worth of ovarian reserve. So should we call it a day and close this chapter here saying that this is what we got? No. We have also come to realize that male infertility is a big part of sickle cell disease, and often they are partners in tribal areas with consanguinity and close-knit wedding. But this study from another friend of mine, which I have discovered in the course of sickle cell discussions, Dr. Vinita Singh from AIIMS Rishikesh, suggests otherwise. When we look at sickle cell subjects and their sperm quality in India, in Chhattisgarh to be precise, we realize that when compared to the WHO reference levels, these levels are far better. And volume, pH, count, motility, morphology, you name it, and all these parameters are improved or higher in populations in India despite suffering from sickle cell disease. The reasons they have pointed out are the patients selected were not receiving any long-term treatment for sickle cell disease, and this could possibly have spared them from the cytotoxicity of the drugs used for therapy. Rays of hope. We need to find some areas where we can work. So ovarian tissue cryopreservation has come to our rescue. We all know that hematopoietic stem cell transplantation is one of the ways to achieve remission in sickle cell diseases. However, that is fraught with the idea of earlier menopause or decline in ovarian reserve. So 6 to 14-year-old girls had their entire ovary removed in this particular setting by laparoscopy for ovarian tissue cryopreservation in liquid nitrogen prior to being subjected to hematopoietic stem cell transplantation. When they were 22 to 23 years of age and pretty much had attained their menopause, these ovarian cells had been, the chunks of ovary were retransplanted into them, and the transplanted tissue was found to be functional. These women eventually conceived by IVF and they achieved live births. So this is a very, very small study, but it gives us some hope that we can have down the years. So with all of these, with hydroxyurea playing a wonder drug in some of these cases, yes, I'm saying what I'm contradicting my own statements, but hydroxyurea is a wonder drug for sickle cell disease, as we shall soon see. With better medical assistance, blood transfusion facilities, penicillin prophylaxis against infections, folic acid treatment for hemolytic anemia, and improved life expectancy, these women today think of conceiving. So once they come to our doorstep asking for what all can go wrong with me and what all can go right, we have to give them answers. So once a patient like that comes to you for a preconceptional counseling, what should you be asking? The first is a history of what all has she gone through in the past, because that gives you an insight into differentiating from pregnancy-induced complications. You ask about headache because tomorrow you might call it worsening of preeclampsia. You have to know about the history of pain crisis, the history of blood transfusions that she has received, because that will lead to more and more antigens going into her body and creating antibodies. You have to know about joint pains. You have to know about avascular necrosis of a femoral head. You have to know about how many acute chest syndrome events has she experienced in the past. You have to take her BP because baseline is frequently lower in these patients, and this has implications as we shall soon see. We have to typically examine the liver and the spleen, which obstetricians usually miss out on because that has critical value in this case. Now, she will ask you, what complications can I as a pregnant woman face due to my disease? So we have to tell her about anemias, infection, a vaso-occlusive crisis, preeclampsia being higher in these cases, preterm labor, and a higher risk of cesarean delivery. Of course, we skip telling her that the risk of mortality is also high. Besides this, pulmonary complications like infections, pulmonary embolism, and acute chest syndrome is what we challenge. What are the fetal or neonatal complications of SCD? She'll be asking. So we have to tell her first about the genetic component of it, that the risk of an inherited blood disorder is looming large. Thereafter, low birth weight, growth-restricted babies, poorer Apgars, risk of stillbirth, neonatal death, and perinatal mortality. Since majority of the genetic part has been beautifully covered by my predecessor, Dr. Veronica, I would be focusing on the obstetric aspects here. So blood pressure, when we take it and we find that it's persistently around 130 by 80 or more millimeters of mercury, then we should be starting therapy in these cases. We routinely perform a CBC count here. And of course, looking at the anemia as a part of it, but WBC count is important because when you have leukocytosis, it has worse prognosis. You should be looking at her iron stores because normally they are not iron deficient. But in our cases, because of nutritional deficiency, sickle cell anemia can exist with coexisting iron deficiency anemia, and we need to look at that to know if we have to supplement iron or not in the future. Also, we have to screen for antibodies that she has developed over the course of years with her blood transfusion. We have to see her LFTs and KFTs because baseline hyperbilirubinemia is normal in these cases because of hemolysis. We have to look at levels of proteinuria more than 50 because if that is so, then we have to look at alternative pathologies that explain kidney disease and not sickle cell disease. We have to look at her lung function. We have to start periconceptional folate. We have to look at her eligibility for long-term anticoagulation. And we have to seek an orthopedic opinion for avascular necrosis of the femoral head. Now, everybody in every part of the world does not have cardiology facilities and cannot perform a 2D echo. However, there are specific indications where 2D echo would be required in cases of sickle cell women, and these include if she has a history of dyspnea, chest pain, she has limitation of physical activity, or she has heart failure or pulmonary edema that she presents with, she has recurrent unexplained hypoxemia, a history of syncope or pulmonary embolism, or a loud P2 or a new murmur that you found that was not discovered before. Now, the medications. We have to give her a therapeutic dose of folic acid because of her increased risk of hemolytic anemia that we have just now decided. The second is vitamin D supplementation, which is as per regular guidelines. Her analgesics, because she will have pain episodes during her delivery. So all of this combined together, we have to first prioritize and give her PCM, and the next would be opioid kind of drugs. NSAIDs have to be used with caution prior to 12 weeks and later than 31 weeks for reasons that are already known to us. They have hyposplenism and autosplenectomy, lending them to a risk of infections. So vaccinations have to be particularly looked into. Besides the routine vaccinations that are prescribed, they have to have their annual doses of influenza vaccine. Meningococcal and pneumococcal vaccines have to be repeated every 5 years. So if she's due for that, that has to be given. And penicillin prophylaxis keeps a lot of infections at bay in pregnancy. They have to continue. Of course, we know what drugs have to be stopped in terms of hypertension. Hydroxyurea, based on the current evidence, is suggested to be stopped prior to pregnancy. However, in cases where blood transfusion is precluded because of a lot of antibodies in these women, they have severe disease and hydroxyurea is what is keeping them under remission, then there can be a one-on-one discussion with a multidisciplinary team and the patient herself to see if this can continue. Iron chelators have to be discontinued prior to pregnancy. Exception with desferoxamine is that it can continue in the second and third trimesters of pregnancy if indicated clinically. Of course, we have to plan her anticoagulation at the same time. Now, how do we identify which subset of women are going to be at the maximum risk for mortality? These are those with pulmonary hypertension, with cardiomyopathies classified as modified WHO class 4, and we know that's a contraindication for pregnancy, and those who have such severe alloimmunization because of blood transfusions in the past that they lack any available matched blood, because that is what they would require in the course of their pregnancy. We have the study which gave us an insight into what all are the factors besides the ones that I've told you that can affect the course of this disease. A lower first trimester hemoglobin, admission requiring vaso-occlusive episodes in the year prior to pregnancy, multiple transfusions prior to pregnancy, sickle cell disease genotype, prior cardiac complications, all of these lend an insight into worsening maternal outcome. When you add to it the levels of LDH, we can also quantify fetal risk with advancing gestation. There are some disease modifying factors also. So if the levels of fetal hemoglobin are high, and that is exactly what hydroxyurea causes. Also, coexistence of alpha thalassemia tends to have a protective effect. The aggravating factors include the high amount of sickle hemoglobin, coexisting spherocytosis or stomatocytosis, and beta thalassemia. And I will really reiterate this idea here that it is important to highlight the kind of sickle cell this is, because that generates the prognostic factors for us. Coexisting alpha thal is protective, coexisting beta thal goes worse. Greater severity with, of course, a homozygous thing, and also with beta null thalassemia, a more benign course with beta plus thalassemia, and with hemoglobin SC disease, as we have discussed in the past. Although adverse effects can be observed in just about all subtypes, ethnicity is a non-modifiable idea. Types of sickle cell disease. Sickle cell is not just a single sickle cell. It is a conglomerate. Genes don't discriminate. So if you have a sickle cell, it does not make you irresistible to others. You can still have a beta thal with sickle. You can still have an alpha thal with sickle. And you can have just about any other kind of hemoglobin with sickle. And that alters the possibility of an obstetric outcome going southward or northward. So it is important to know the mutations that you should have. So whenever a lady is coming to you with a prenatal idea, you should at least talk to her about this and identify her mutations, because that is what you'll be looking at in the CVS later. Now, sickle cell trait. Of course, more than disease, the trait is common. So what happens? What are the adverse pregnancy outcomes with sickle cell trait? In the study of about 5,000 pregnancies, we discover that they have a milder form of problem, so that preeclampsia, etc. are not increased, but vaginal births are fewer, and the rates of intrauterine fetal demise are higher with trait as well. So trait exactly is not a benign situation, and this should also be viewed with concern. During preconceptional counseling, we have to identify the risk to the progeny as well. So this is a ready reckoner for what can happen So if a lady is sickle cell and the partner is an alpha thal, you can see that there is no risk. Similarly, if the lady is sickle cell and the partner is also sickle cell, then you are leading to a graver outcome and you need to offer prenatal diagnosis. So this kind of a chart can actually help you identify women who would require to go to the genetic counselor. Of course, all of these women should go to a genetic counseling. It is important to identify the genotype of the partner here, as we have already discussed. Now, coming to some scenarios, these have primarily been concerned by Dr. Veronica, so I'll be just quickly going through them. A patient comes with preconceptional period and does not want to potentially have an affected progeny. So you can offer a PGT-M or monogenic disorder PGT. Of course, what I want to highlight here is that any such case who has conceived despite knowing with PGT that the baby is not affected by thalassemia or sickle cell disease, these have to be prenatally confirmed by invasive testing yet again. And PGT-M is not a short idea that you should take forward from this particular discussion. If a patient presents after conception, we have already beautifully discussed that they can be offered prenatal testing in terms of CVS or amniocentesis, depending upon when they appear to us. Prospective parents, if they want to know about therapies for sickle cell disease, yes, they do exist. We have hydroxyurea, which is actually a good drug. Nowadays, we also have other drugs like voxelotor and L-glutamine. And recently in December 23, the FDA has approved the landmark gene therapies, which are the way to go. Scenario 3 is both parents are homozygous for sickle cell disease, which means 100% of their progeny is going to be affected. Here, donor gametes can come to our rescue and pregnancy is still possible. NIPS and prenatal screening for sickle cell disease is still in research stages. It has not been validated for clinical application. So for those of us who are very, very big fans of NIPS, our patients would like to know whether that can be applicable to sickle cell disease also. Coming to obstetric outcomes in sickle cell disease. So we have this beautiful systematic review and meta-analysis that tells us that rates of maternal mortality, the relative risk is about around 6 times. Of course, this can be 10 times, this can be 30 times, depending upon which part of the world we are talking about, because the prenatal care is not identical across the globe. The rates of preeclampsia are about 2.5 times more, stillbirth around 4 times, preterm delivery around 2 times, and rates of growth restriction around 4 times. Now, this paper, which dealt with about 57 million pregnant women, including over 54,000 sickle cell disease, tells me that when you talk of any kind of preeclampsia and sickle cell disease only, the rates are higher by say 1.2 times to 1.6 times. But when HIV is coupled with sickle cell disease, the risk of preeclampsia goes 3.62 and 4.28 times, giving me the idea that the odds of developing preeclampsia, including severe preeclampsia, are increased with concomitant HIV infection. And initiating aspirin 150 milligrams every night is a very, very profitable idea that we should be taking home from this presentation. Next challenge that we face in pregnancy is vaso-occlusive crisis. It can be uncomplicated, where there's no evidence of organ dysfunction, and this may last up to about say 2 weeks or so. There can be complicated variants where there is end organ damage, and multidisciplinary management and blood transfusions would be required in addition to the basic ideas. The initial workup would consist of CBC with a differential count, LDH, a comprehensive metabolic panel, urine analysis, and a chest X-ray to see if the patient has respiratory symptoms, hypoxia, or significant decrease in hemoglobin levels. Otherwise, chest X-ray is not what we not normally do in pregnancy. The supportive therapy in form of oxygen would be required. IV fluids would be required. It has to be particularly mentioned that these have to be acetonic fluids and they have to be given judiciously to avoid pulmonary edema in these cases. Analgesics have to be prescribed for the pain crisis. If it is complicated, we have to introduce blood transfusions as well. Coming to an acute chest syndrome, leading cause of death among patients with sickle cell disease, diagnosed by new pulmonary infiltrates where none existed before, and along with that, any one of the rest of them, such as foreign oxygen saturation, cough, high-grade temperature, tachypnea, or wheezing. Management is multidisciplinary. So besides the supportive therapy we just discussed, we have to add broad-spectrum antibiotics. We have to see that blood transfusions are given so that the sickle cells come to less than 30%. And intensive spirometry has to be offered very, very frequently to these patients to tide over the crisis. Now, what is the role of prophylactic transfusions in sickle cell disease? The entire idea is anemia. But there is a lot of controversy regarding whether they should be routinely given or not. After a comprehensive discussion with a lot of people dealing with these situations firsthand, what I've realized is that transfusions have to be given to maintain levels above 9 grams or so which is the normal course in pregnancy even otherwise. They should be considered when prior or current medical, obstetric or fetal concerns exist due to sickle cell disease, because we have to keep the hemoglobin levels above 9 and sickle cell population less than 30%. If the woman was earlier on hydroxyurea due to severe disease and we had to stop it prior to pregnancy, then these women would require transfusions to maintain their blood levels. Multiple pregnancy calls for transfusions. For prevention of stroke, transfusions are indicated, and for management of acute complications like acute chest syndrome and stroke. Of course, the blood that has to be given has to be CMV negative, HBs negative, and has to be extensively cross-matched against all possible alloantibodies that the patient might have developed. All reproductive age female are given RH and also KEL matched blood, and that goes without saying. For prophylactic transfusions, the target is 9 to 10 grams, as I discussed earlier. The potential adverse effects include delayed transfusion reactions, in addition to the acute ones that we face, more and more alloimmunization with every transfusion, infections that potentially might be carried with blood, iron overload. And how do you avoid this? By using exchange transfusions in place of only simple transfusions, by extended antigen matching so that alloimmunization is prevented, and using alternative drugs such as erythropoietin and hydroxyurea. Now, how do you do fetal surveillance in these cases? For sickle cell disease and for sickle cell beta null version, where we know that we are going to be at a higher risk of complications, fetal growth surveillance has to begin 4 weekly, starting 28 weeks onwards. For trait, we can actually resort to this kind of a surveillance beyond 32 weeks or so. Now, some pregnancy specifics. If a lady with sickle cell disease comes to us with hyperemesis, we know that dehydration, hospitalization, both are going to increase her chances of a vaso-occlusive crisis or an acute chest syndrome. And therefore, along with other supportive therapy, thromboprophylaxis has to be initiated. For preeclampsia, we know that they have a baseline lower BP. Despite that, the risk of preeclampsia is actually higher. So even if she is not meeting the traditional cutoff of 140 by 90, 4 hours apart, twice over, if there is an increase in systolic BP by 30 millimeters and in diastolic BP by 15 millimeters of mercury, she is preeclampsia and she needs to be kept under surveillance. Microalbuminuria can be secondary to renal development also. So you should have a baseline to be able to call it preeclampsia. And headache will also be a manifestation of neurological disease, and therefore prior history comes to your rescue to differentiate. Blood has to be kept ready. Extended antibody screen has to be done 2 days prior to delivery at least to be better prepared with any exacerbations. And make sure availability of adequate blood products. Mode of delivery, we prefer vaginal birth in these cases, and cesareans are restricted to only obstetric indications. Time of birth in uncomplicated sickle cell disease is 39 to 40 weeks gestation, like for everybody else. Complicated, obviously, we need to individualize. Now, coming to very little outcomes with compound heterozygous, wherein we talk of thalassemias. Now, here, postpartum adverse events are more common with sickle beta combination, as I said, and also with homozygous sickle cell. And therefore, it is extremely important to know the genotype of the patient that we are dealing with. Postpartum considerations, lactation, we have to impress upon them that lactation is a good idea and they should continue with it. Implications of medication, we had stopped hydroxyurea and this can be restarted in lactation period. And we have studies to prove that the blood levels of, breast milk levels of hydroxyurea are not very, very high. And they are much less than therapeutic doses of hydroxyurea that are routinely used for neonates and infants. And therefore, hydroxyurea is a safe drug in lactation. The lower panel here tells us that the amount of secretion in the breast milk is identical in sickle cell disease and in normal women. So the drug can be safely used in pregnancy. In lactation, I mean. Contraception for women with sickle cell anemia. Progesterone-only contraceptives are a good idea because estrogen component tends to increase the complications of thromboembolism, which these women are already prone to. So the Society of Paternal Fetal Medicine statement about this says that sickle cell disease is one of the risk factors for precluding pregnancy. They avoid pregnancy in such cases, and therefore they prescribe long-acting reversible contraception in the form of an LNG IUD. A Cochrane review between DMPA and placebo, where the outcome was any pain episode during 30 weeks of follow-up, favors giving treatment, which means offering medroxyprogesterone acetate to these populations is associated with reduced risk of sickle pain crisis, which is an additional benefit in this case. Now, coming to pregnancy outcomes in women with sickle cell across the globe, we realize that the risk of thromboembolism in women with sickle cell disease tends to get increased in the third trimester and also postpartum. Therefore, it has been advised that provided there are no contraindications or risk of bleeding, postpartum prophylactic anticoagulation should be considered for all women with sickle cell disease if it has not been given earlier. And of course, I would like to revise this traditional, very popular 37A green top guideline on prophylactic disease, which enlists some contraindications to LMWH use, including hemorrhage, including acute stroke, severe renal disease, liver disease, and uncontrolled hypertension. These are contraindications which should be borne in mind. Early ambulation and compression devices, which are non-pharmacological therapies and preventive measures, should also be kept in mind when dealing with these women. In addition, pain is a genuine problem with them, and we have to have our options in place, including gabapentin, including regional blocks, should the need arise. Reducing acute chest syndrome crisis in postpartum period is again important, and therefore offering intensive spirometry in this period should not be underestimated. Long-term optimization would require liaison with sickle cell disease physicians and maternal fetal medicine people. Women in our part of the world particularly come to the hospital only during pregnancy. And this should be sort of as an opportunity, a window of opportunity to actually manage them in the longer term also. And liaison with these physicians will help them come to the hospital more frequently and live better lives. Coming to sickle cell disease and pregnancy outcomes, and this is a chapter that I'm really looking forward to share with you. This is a publication by Dr. Gayatri Desai, the chairperson of this session. So this is the story from our part of the globe. We have reported 90% live births, less than 50% women requiring blood transfusions. We have reported that approximately 75% of individuals have a birth weight of more than 2 kg. 72% of these women have delivered full term. Only 23% have required a cesarean section. 62% have dealt with sickle cell crisis, and yet these outcomes. Pregnancy-induced hypertension has been experienced by 8% of women. What is not there to applaud in this data when the entire literature the world over is predicting doom? Hydroxyurea, the magic wand. Hydroxyurea has vascular effects, but primarily in sickle cell disease, it works by increasing HbF values. In addition to this, it causes decreased polymerization of sickle cells. It decreases WBCs and platelets also, leading to less endothelial activation in addition. That leads to less RBC membrane damage. They're more stabilized, so decreased hemolysis and increased hemoglobin. Less WBCs, less platelets causes less thrombosis and microparticle activation, leading to less vasoconstriction and improved tissue oxygenation and decreased inflammation. This has sustained hematological benefits, fewer acute chest syndrome events, less preeclampsia and FGR, improved growth, preserved organ function in the dose of 15 to 20 milligrams per kg per day. The drug takes some time to take its effect, between 5 to 12 months. So the final print is that hydroxyurea given to women in pregnancy, and the outcomes are that there was no teratogenic effect or malformations. At 36 months of follow-up, there were no delays in their milestones. The mechanism that has been offered is that preterm births and abortions in sickle cell disease can be attributed to the granulocyte colony stimulating factor. With hydroxyurea, there is a decrease in WBCs, corresponding decrease in this GM-CSF, leading to a prevention of preterm births and abortions. This is speculative, but yes, this is the future. What is the role of hydroxyurea in sickle cell disease? This is a letter to the editor, Ethical and Clinical Considerations in the Use of Hydroxyurea in Pregnant Women with Sickle Cell Disease by Dr. Desai, that says that hydroxyurea is currently not recommended in pregnancy. It is mostly stopped in the first trimester, might have to be started in the third trimester again in cases of severe transfusion-dependent anemia. And why can't it be given to pregnant women? That is the letter to the editor. So the take-home messages are: routine aspirin prophylaxis for preeclampsia is important. Managing dehydration, simple measures like keeping the patient warm can go a long way. Thromboprophylaxis is important, and giving them adequate contraception so that pregnancy, unintended, unplanned pregnancy is minimized, can go a long way in improving their condition. So if the international story is not what we like, let's create a national one. That is the take home from this talk. Thank you so much, each one of you, for bringing sickle cell disease to the fore. Thank you to the government of India for bringing in rarer diseases into its ambit. And thank you, Society of Fetal Medicine, for this opportunity.
Thank you, Dr. Jaya, for a beautiful talk, covering very comprehensive talk. Is Dr. Gayatri here? I can't see her. I've been wanting to her because you have highlighted all her efforts in this in the endeavor to treat these women, and she's doing amazing work. So I wanted her to be.
Yes, Dr. Sita, I'm here.
Dr. Deepa. Yes, hello. Good
Yes.
evening.
Good
Thank you
evening,
so much.
everyone.
Yeah.
Good evening, everyone.
I want your expert
And
comments and as well as your, I congratulate you on your work and your efforts in this endeavor. So over to you. Thank you.
thank you. Thank you so much. Thank you for giving me this opportunity to present my ideas to esteemed audience here. And thank you, Dr. Jaya, for a detailed and elaborate presentation. You actually talked a lot of what I was about to say. But just to just to recapitulate, we work in rural and tribal area of Gujarat, and the sickle cell gene prevalence here is like around 18%, 16% of trait and 2% disease. What my experience comes from our center, which delivers around 6,000 women every year. And we see new antenatal cases around 15,000 every year. And so every single patient gets tested for sickle cell disease. So we have a good data set of last 15 years from which we just published, and the other paper is about to be published. We are also doing prenatal testing. Just coming to the point of using hydroxyurea in pregnancy. I'm very excited about use of hydroxyurea in pregnancy, and I'd like to just talk about why we should consider this thing. As we know, the maternal and fetal outcomes are poor in sickle cell disease. The maternal mortality can be as high as 30 times the normal population. And newborn mortality and morbidity is also very high. Secondly, we know hydroxyurea works well in non-pregnant women. It's like a proven drug. Thirdly, we have been using class X drugs in pregnancy. Currently, everybody is prescribing, say, propylthiouracil for hyperthyroidism, or valproic acid for epilepsy, or warfarin for patients who have had mechanical heart valves. And all of these drugs have proven fetal toxicity. In spite of this fact, we are using these drugs. Now, on the flip side, the published literature with use of hydroxyurea in pregnancy have not seen any increase in fetal malformation. So my ask from the audience is to consider at least to consider hydroxyurea use in pregnancy, and it should be taken up as a research topic. At least we should try to explore use of hydroxyurea in pregnancy. We are about to start RCT for taking the same topic, and we hope to see some results. That's all for this evening. And thank you, everyone. Thank you.
Thank you so much, madam. Over to you, Dipanjana.
Thank you so much, Dr. Gayatri. It's always a pleasure to talk to you and listen to you, and also read your papers. Actually gives us a lot of insight. Thank you, Dr. Sita ma'am, for chairing the session, and Dr. Gayatri ma'am, and thank you, Dr. Joya ma'am, for such a wonderful and elaborate and a beautifully paced talk, I should say. So we come to because we are speaking about tribal areas, and this is a problem that has evolved from the tribal areas. Our next talk would be based on the same, and this would be our session 4, where I am grateful to invite Dr. Ananya Basu and Dr. Ojaswini ma'am to chair the session, Dr. Ojaswini Patel ma'am to chair the session, which will be on strengthening health system for implementation of NSCAM, experiences from the tribal dominant states of India. And I'm grateful to Dr. Yogesh Kalgode sir to agree to give this talk. And I welcome our chairpersons, Dr. Ananya and Dr. Ajaswini ma'am, to please for this session. Dr. Ajaswini Patel ma'am is a professor and project officer at Burla. She's an executive member and ex East Zone chairperson at ISOPARB. She's a coordinator ISOPARB Burla and Sambalpur chapter and Burla ONG Society. She's a vice president of National ISOPARB and president Burla ONG Society. She has numerous awards, numerous publications, and her special interests are high respect.
That's all, Dipanjana. Thank you. Thank you for
Thank you so much, ma'am, for agreeing to
ma'am.
chair this session, and apologies for changing your time.
No
And
problem.
we have and we also have Dr. Ananya Basu, who's a fellow in fetal medicine, FFM UK certified. She's a fetal medicine specialist at Petals Health. She has esteemed memberships in number of these societies, RCOG, the society. She's an executive member at Society for Fetal Medicine. She's secretary Fetal Medicine and Imaging Committee Bogs. She has published in numerous journals, both national and international. Welcome both of you, and I would request to please introduce our esteemed speaker, Dr. Yogeshwar Kalgonde sir.
Thank you, Dipanjana. So at the outset, I am very much thankful to the Society of Fetal Medicine Bengal chapter, especially Sita madam, for allotting me in this great webinar. And I belong to an area where the sickle cell is very rampant. And in our institution, it is a very dreaded problem. You can say almost the second cause of the maternal mortality. In our institution, the number one being the eclampsia, but second one being the sickle cell disease. So such a dreaded problem here. So to deliberate on this topic, especially about this program, the topic is strengthening health system for implementation of National Sickle Cell Anemia Mission, experiences from tribal dominant states of India. So this will be dealt by Dr. Yogesh Kalgode sir. And to introduce him, he is MD Medicine, MSc Clinical Investigation from USA, MD Neurology from USA. And he has many, he is the Public Health Practitioner and Researchers Executive Committee member, Sangwai People's Association for Enquiry, Equity and Health, a not-for-profit organization working in Ambikapur, Northern Chhattisgarh. 13 years of experience in working with
Madam, if I may please interrupt.
Okay.
Madam, in the interest of time, I think we can skip this, and then I would like to present the work, and I think the work will sort of speak for itself. So
thank you. Thank you,
yeah, so thank you very much, and it's a real pleasure to be here. And what really sort of impresses and inspires me is that you have more than 50 highly trained doctors present on this webinar at 10 p.m. So that talks a lot about the dedication and the commitment, and I'm really sort of looking forward to show the work that we have done, but at the same time get guidance from you. As I said, this is the fetal medicine is not at all my forte, and the disclaimer I have is I'm a neurologist who likes to wander in rural and tribal areas and identify problems and try some of them that we can solve. So I'm going to talk about what we have been able to do in Chhattisgarh. And at the outset, I would like to thank Dr. Gayatri Desai and Seva Rural for the wonderful work that they have done. And it has really helped us sort of work more on this problem. So with that, I'll be sharing my screen, and I hope everyone is able to see it. And let me see. Okay,
Sir,
great.
you can please make it full screen, sir?
Yeah, I
Yes,
did
sir.
it. Yeah, is it okay?
Yes, sir. Perfect. Thank you.
Wonderful. So I actually like the note on which Dr. Chawla ended, that we have read international stories. Let's start with our own. And we have Dr. Gayatri's story, which is our own, and this is another story that can be our own. So I work in Chhattisgarh, as all of you know. This is a state with, it's a gifted state with a lot of natural resources, so wonderful forests and rivers. But it's also one of the poorest states of India. A third of this population is tribal, and this tribal population is largely located in the northern and southern pockets. So all of you must have heard of Bastar because of left-wing extremism activities. We work in the northern part, which is also tribal. Care seeking is largely from public sector, meaning that there are not many private practitioners in general in this state as compared to other states. So people tend to go to public hospitals, government hospitals. And another interesting thing about this state is the concept of ASHA actually was operationalized in Chhattisgarh first. So that's the gift of Chhattisgarh to rest of the India. I worked with a not-for-profit organization called Sangwari, where a group of 8 doctors who are interested in rural and tribal health. We work with rural and tribal communities, and we work on various aspects, including sickle cell disease, pain and palliative care, tribal health, so on and so forth. So why in Chhattisgarh sickle cell disease is important? Because 1 in 10 individuals in Chhattisgarh carry this gene. So every 10th person you meet is likely to carry this gene, and 1 to 3 per 100,000 individual, or about 0.1 to 0.3% of the population will have the disease. So it's a public health problem when 1 in 10 person carries the gene. But there were also multiple challenges. So one was there was lack of clarity regarding screening and diagnosis of sickle cell anemia. It's a 2-step process usually. A screening test is done, and if it is positive, then you go for confirmatory tests. The state tried to do a large population level screening in 2017, but they didn't have, it was not backed up by availability of confirmatory tests. So the whole effort sort of went down the drain. Confirmatory tests were not easily available until very recently. Doctors were not confident of using hydroxyurea because it's considered an anti-cancer agent, and the primary care doctors were very reluctant. So, and then this despite it was being freely available in the public health system. So it's like for patient, it was like in Hindi, as they say, pani mein reh ke pyasa. So there was hydroxyurea freely available, but patients were not getting it. So what has this led to is over-reliance on blood. So with pain crisis, patient will come with anemia, and all the treatment that the person will get would be blood transfusion. So it almost started, getting treated like thalassemia, where you actually do not need blood in many of the patients of sickle cell disease. There was no regular follow-up. There was discontinuous documentations leading to multiple repeated tests for screening and confirmation. Pneumococcal vaccine, which have been talked about, was not easily available. It's still not available. Penicillin prophylaxis was also not there. So what does this lead to? So, these are poor people who are suffering from poor control of symptoms. So the children will be, writhing in pain. Adults would be in pain and will not be able to work. There's loss of school among children. Adults lose wages. Many times they cannot work, especially in agrarian community where you have to work in farm. Patients with sickle cell disease cannot do heavy physical work. They will end up getting admitted with a crisis. So it puts entire family at risk of poverty. And it also leads to early disability and death. So avascular necrosis occurs in late 10s and 20s and 30s. And it's really heartbreaking to see children of, a young adolescent of 15 years old, limping because of loss of the hip bone. So the question that we asked ourselves, can we streamline, improve care of a patient with sickle cell disease in the public health system? So, we being working in an NGO, it's always challenging to work with the government and change things. So we decided to work in 2 districts. There are 2 districts called Surajpur and Sarguja with a population of about 1.5 million. And about 50% of the population of these 2 districts is tribal. And what we said is, can we have a target and start seeking a target? So we defined a care package for which we would work and try and push for this care package. So care package included, availability of diagnostics like screening tests and confirmatory tests, and making these tests available round the clock without any, interruption in availability. Then work on uninterrupted availability of hydroxyurea, improve pain management of these patients, push for pneumococcal vaccination and antibiotic prophylaxis, and push for protocol-based, care and social work support, along with linkages. So the patient who need higher level of care can be linked to higher systems, and those who are stable can be pushed down to lower level facilities, which are closer to patients' homes. So we were very skeptical whether we can do this. And so we started with an urban primary health center in the town of Ambikapur. And this is a small but very well functioning health and wellness center of the public health system. So we got one doctor who got interested in treating patients with sickle cell anemia. Earlier, no patients were seen in this facility with sickle cell anemia. So we trained this doctor in use of hydroxyurea as well as proper monitoring, and we handled this doctor. So one of us used to sit with him, and so that he gets confident. And at that time, this was about 2 years ago, when the point of care tests were not that easily available. We made it available at this facility so that the confirmatory diagnosis can quickly be done. And at that time, there was no, facility for giving patients a sickle cell card. So we started it at this health facility where we started, giving these sickle cell cards to patients regularly. And patient came because with this card, they could get free medical care in the public health system. And so we started with this humble effort. And today, this medical officer alone manages close to 400 patients with sickle cell anemia, more than probably what you will see at AIIMS in Raipur. So this gave us hope that we can do something in the public health system. And so then we decided to expand it to 2 district hospitals. And we decided that this is a complex problem, so we need to have a complex intervention. So we did, about 7 interventions. So first was we deployed a team of care coordinators. As you all know, that medical colleges and district hospitals are very busy places, and sickle cell disease is one of the diseases that they treat. So patients with sickle cell anemia, if you want to improve their care, someone needs to anchor care for them in a very busy public health system. So we deployed these care coordinators. We created a telephone helpline on which patients can call at any time. These care coordinators followed up with the pharmacy and the store to make sure that hydroxyurea is regularly available. There are no outages. We developed simple training material for doctors as well as awareness material for patients. And as I mentioned earlier, we created upward and downward linkages within the public health system. And then we started building a community of doctors and patients. So doctors were not at all confident prescribing hydroxyurea. There were very few doctors, like maybe 2 or 3 doctors who were comfortable prescribing hydroxyurea. The rest were not, even at the medical college, local medical college. And patients were completely unaware of what this disease condition is. They got very conflicting messages. We had, individuals who were sickle cell trait were asked by doctors not to marry, and they were unmarried. So these care coordinators started systematic patient identification and enrollment by visiting district, inpatient wards every day and creating a registry and then actively tracking patients. They also ensured that doctors started them on hydroxyurea and provided counseling. They provided active follow-up. So all these patients would get a phone call every month to make sure that they are coming to the hospital and getting their medicine. If they don't show up after 2 visits or 2 phone calls, the team will make a home visit. And we focused on training healthcare providers, and we started doing advocacy in the state. So this is a team of care coordinators which sits in the district hospital, and it's like a secretariat for the patient to keep all the data and give them advice. And when the patient gets admitted, the team goes and visits the patient, gives them encouragement, helps them navigate the health facility, helps them with, if they are needing blood transfusions, they will go with the patient's family members to the blood bank and help them arrange blood. And if the patients don't show up, the team makes home visits and to try and understand why patients are not coming. Oftentimes, in medical practice, we easily label these patients as non-compliant, but there are serious socioeconomic issues that these families face because of which they can't come. And oftentimes it's the poverty that, sort of dissuades them from regular follow-up. We train doctors in case scenario-based management. Instead of providing just theory, we gave them case scenarios to solve, and the doctors got interested, and then we built their theory. We did active handholding of doctors, and then we created a simple material. So we realized that calculating dose of hydroxyurea is 15 to 20 milligrams per kilo. And then we only had hydroxyurea available as 500 capsules, needs a little bit of mathematics and some juggling in your head. So to make it simple, we just converted it into a TB-like treatment, a weight band-based treatment, and a simple algorithm to how to follow up. So 2 A4 size papers actually pasted on their walls. And we created a simple 3-page booklet for them to read through and understand hydroxyurea. And for patients, we created simple booklets for continuous follow-up. So if you go to larger hospitals, for continuity of care, you need to have patient booklets. We created them. We created treatment linkages. So if the patients had avascular necrosis of femur, then we tied up with a doctor at the AIIMS Raipur who was expert in this area. And then we started referring patients to him because patients were unaware where to go for good quality care. Prenatal diagnosis was not available. Entire state has just one facility where these services are provided. And then for stable patient, we started pushing their care to community health centers. Then supporting pregnant women, because we realized there were deaths among pregnant women, and it was really heartbreaking to see. So we started active follow-up by our team that a monthly follow-up has to occur. We get their appropriate investigations done. The team helps with blood transfusions and provides travel support for poor patients. Then we went on to radio to increase awareness, and this is the medical officer in the public health system who we sort of motivated to go into radio and increase awareness. Then we started building community of patients. So, it's a chronic disease, lifelong disease. So we need to build capacity of the patients. Otherwise, it would be just, it's not purely health system's responsibility. Empowered patient can really help improve their own care. So we started patient peer support group meetings at these district hospitals. Then we started inviting patients for sickle cell day. All at these district hospitals, usually sickle cell days were celebrated just in presence of doctors and nurses. So we started inviting patients as stakeholders into these sickle cell day functions. There was increased awareness on the sickle cell day, and we worked with the government machinery to increase awareness through rallies and functions. And then we started a novel initiative called Sarguja Sickle Cell Janaswasthya Sammelan. So it's People's Health Conclave to bring patients together. And we did that last year, and the next Sammelan is next week. So where 300 to 400 patients and their family members came together, and they directly interacted with the health minister on a video conference. And we felicitated doctors in the public health system who provided good care to these patients. So nurses, lab technicians, store managers were felicitated at the hands of the patient. And that really increased enthusiasm among patients. They realized that they are not alone, and there are many more people like them. And so with these interventions, what are the outcomes? So we saw that there were about 1,100 patients, 1,200 patients are now enrolled at 2 district hospitals, and these are all SS patients. We look at, we make sure that there is gender equity. So 51% of our patients are women, because sometimes women are left out from seeking care for various reasons. Then we look at age equity. We are trying to push that the patients with sickle cell disease get diagnosed early on, and so that the care can start early with hydroxyurea. Then we started putting these patients on hydroxyurea, and these are data which shows out of patients seen every month, how many were put on hydroxyurea for the first time. And on an average, 75% of the patients were put on on hydroxyurea for the first time in their life. Then we looked at what is happening. So we went and sat with these doctors for first 3 months, and then we stopped going. And just to ensure that these doctors are prescribing hydroxyurea, we looked at how much hydroxyurea was where these facilities were dispensing. So we got this information from the stores. And at the district hospital, which was also affiliated with medical college, the hydroxyurea use went up from 1,800 capsules a month to close to 17 to 18,000 capsules a month. And another small district hospital, it went up from 150 capsules a month to close to 6,000 capsules a month. So there was definitely increase in use of hydroxyurea. The doctors have become confident. Then we looked at what was the follow-up rate of these patients. So we defined good follow-up as any one visit in the past 3 months. So these are data for April to June 24, and out of the total enrolled patient, close to 81% followed up at either these district hospital or one of the CSCs. And at the other district hospital, 75% patients followed up. So these are very good follow-up rates considering the public health system. But through our care coordinators, we can keep active track, and we keep on motivating these patients. And what happens when you start giving hydroxyurea properly? So this is a percentage of enrolled patients who are needing blood transfusion. And you can see that this has gradually come down. So we are hoping to keep this percentage under 2%. And the same thing that happened with hospitalization, the percentage of enrolled patient needing hospitalization also came down from on an average of about 10-12% to less than 5% now. So this is again in public health system, which is very chaotic. So it's not like one NGO doing a center of excellence work. But we continue to have challenges. So as I said, the prenatal diagnosis facility was not easily available. The doctors themselves were not aware that such a facility existed. And this is very interesting that even in states with very high prevalence of sickle cell disease, the awareness among doctors is very low, and we have to do a lot of work. And government's mission coming in has really helped. And as I said, there is only one center that was doing it in Raipur, which is about 350 kilometers from where we work. But the good thing was these services were covered under Ayushman Bharat. So we could link these patients through Ayushman Bharat. And we actually started guiding and handholding the patients because of very regular follow-up. We could do that. And this is a couple that went through the testing, and the genetic testing was done. And so far, we have helped 6 couples, and there were total 7 prenatal tests done. On one lady, there were 2 tests done. And pregnancy was continued in 5 patients because the patients were either the fetuses were either A or AS, and medical termination of pregnancy was opted for by 2 pregnant ladies. And now we have, over the last 2 years, we have centralized this care, and we are happy with, reasonably happy with the care that is there at the district hospital. We are now trying to push it at the community health center, which are the block level hospitals in the public health system. So right now we have reached to 6 out of total 12 community health centers where our team goes and conducts once a month clinic with the medical officers available at the CSC. And we hope over next 1 year, we reach to all 12 blocks soon. So there will be gradual decentralization of the care. So what happens when you do this? We got family testimonials, and this is obviously expected that the child who was in a lot of pain is now pain-free, and they are able to go to schools. And the community said that for the first time, we feel supported and guided by someone. Otherwise, we're very confused. So based on the results in 2 districts, the UNICEF in the state got interested, and now we are scaling up in 2 more districts called Jashpur and Durg. With them, and we now have close to 1,600 patients enrolled with us in all these 4 places. The work in the Jashpur and Durg has just started 2-3 months ago. So to share learning with you, we were pleasantly surprised that there is a feasibility of integrating care for sickle cell disease in the public health system, where most of the poor and tribal patients seek care with appropriate guidance, handholding, creating simple tools. And simple guidance and tools led to improved prescription of hydroxyurea. A team of non-doctor care coordinators or counselors really helped these patients significantly because they anchored the care for these patients in the public health system. Communitization of the care and building of patients' awareness and voices are very important. So we use some innovative approaches like patient conferences, active involvement of patient, and now our care coordinators also involve patients. So they have actually peer counselor. So we have 2 patients with sickle cell disease who work with our teams, and they counsel patient. And when it comes from their mouth, it carries much weight than if I say something. So it's interesting that we have a model of care for sickle cell disease emerging in this public health system. And what we try to set up is now we are gradually developing a care ecosystem within public healthcare system to gradually improve all aspects of care in patients with sickle cell disease. But there are persistent challenges. Pneumococcal vaccine is still not available to patients who are more than 1 year of age. Pneumococcal vaccination is included in under 1 year in the current immunization program. Penicillin prophylaxis for children, the pediatricians are still hesitant to write daily penicillin. Maintaining uninterrupted supply chains is a challenge at times. Surgical care is challenging because there could be high surgical morbidity. Prenatal diagnosis, I think there is need for more facilities, more training in states like Chhattisgarh, and professional societies like you can really sort of come in and help build this capacity. Maternal deaths, unfortunately, is still a reality in this part. A lot of time by lack of diagnosis or not seeking care in a timely manner. Awareness among patients and communities is an ongoing process. And also patients, we have developed we have formed a community of patient advisors for our program, and they said that you also need to work on social determinants. So disability benefits and pensions for these patients, school dropouts. How do we work with the education system to prevent that? Like lack of livelihood for patients and need for skilling, and now we will start a project to actually provide skilling for these patients so that they can't do heavy physical work, so they will have to do light work. And community level dialogue for premarital screening and essentially using patients as advocates. And this work will also start soon. So with that, I'll stop. And again, as I said, it's a huge work with lots of teamwork. And you can see a bunch of stakeholders who are involved. And without their support, it will not have been possible. So with that, I'll stop and thank you all for your patient listening, and really sort of impressed that you being so active at this time of the day. Thank you very much.
Thank you, sir, for your excellent work on the state of Chhattisgarh. And definitely, we are discussing many things, but when you are very less people are directly approaching to the patient. So heads up to you, sir. You have just gone towards the patient, to the village area, to the rural area, and being a neuro specialist, you have adopted the disease, which is a very common disease, and you have gone to the patient, social activity like thing, and you have help the women and help the population to a great extent by giving awareness, by giving handholding support, and giving the guidance to the patient for the proper treatment. And all of us should learn from you how to do this activity and how we should be involved. So I know that you're involved from your heart, from your brain, from your hand, from your mind about these patients. Thank you, sir, for your commendable work.
Thank you, ma'am, for very kind words.
Hats off to you, Dr. Seriously.
Very, very commendable, sir, indeed. This is inspirational.
Yeah. Ananya, you want to have a few words here? So, Ananya, yeah.
So this whole session was very, very enlightening, and I am really thankful that I could be a part of this. And I really find this kind of activity so commendable. I mean, this is real work, going to the grassroots levels and doing something that is really meaningful and worthwhile. So, and especially a special note of thanks to all the speakers, and also to Dr. Gayatri Desai for her original work, and she made us so proud. So thanks to all of you. This was so enriching for us.
So thank you all the chairpersons, Dr. Ananya Basu, Dr. Ojaswini ma'am. Thank you so much for being a part of this session. Thank you, sir, for such a wonderful work, and it actually makes us think that we should be more towards these rural areas and really be at the grassroots level of the problems. And I am so glad that Dr. Deepa, Dr. Gayatri, Dr. You yourself in Chhattisgarh, you have been making such a change in the rural level. And it's also commendable to see that everywhere we are talking about less of fetal medicine people to be trained in the government sector or in the district hospitals, so that they can reach out to you. And here I should mention that Dr. Kanchan Mukherjee sir and Sita ma'am actually has started a project where they are actually in Bengal. They are trying to train these people, the fetal medicine people in the government sector, so that there is more accessibility for everyone. So I feel we all have a role over here. And if there are any questions, most of the questions were answered on the way. But if there are any questions which is there, or if the entire panel feels the need for any discussions, I would like to ask all the panelists who are present at the moment to switch on their cameras. And even if there are any kind of questions from the audience, we are ready to take it. Though I know it's pretty late, but we can dedicate 10 minutes for that if there is any. Deepa, I would like to ask one question. Like, as a state, Karnataka has actually done a lot for genetic disorders. But is there any of these trainings going on for fetal medicine in the district hospital, or any accessibility that is going on there? Like any accessible way that a prenatal diagnosis is accessible to people?
Absolutely nothing, because only first of all, the awareness, as mentioned by Sir Yogeshwar sir, the awareness about the need for prenatal diagnosis itself doesn't exist among the specialists. So we are literally struggling to spread awareness in different platforms, whether it's Foxy, IAP, in different ways we are trying, and non-availability, only few, like number of people who are practicing in different districts itself is very low. They have to travel a very long distance and wait a long time. And also by the time report comes, also they would have crossed the age of termination, then apply for the board. All these challenges are making them demotivated to reach for prenatal diagnosis.
So my next question would be actually to Yogeshwar sir, because sir, you are a neurologist, and this is a bit of an offshoot question. But you do travel to these rural areas, and you have seen sickle cell cases. But what is the prevalence of other genetic disorders? Do you think that they also should come in the forefront, like any other particular disorders that you feel are also like there in prevalence, as far as prevalence is concerned?
So in terms of common genetic disorders that we come across is blood disorders, sickle cell and thalassemia. So both are common. And other than that, I think there is relatively less data on other disorders. And where we lack is essentially data poverty in rural areas. So we don't even know. A lot of things are not known for rural India. So it's very hard to comment. I mean, even sickle cell took 40 years of just studies. All the studies were prevalence studies, and finally, someone could convince the government that you should launch this. So I think we'll have to reimagine. Now India is changing, and we are really sort of, we need to reimagine healthcare, and we have so much inertia that we have got used to not being doing any genetic testing. So I think it's up to you to lead. And as Dr. Deepa mentioned, that this discussion now needs to come at the professional organization, and they should start pushing, because one of the responsibilities of professional organization will also to build capacity. And that's how, I mean, you are trendsetters in the field. But can we do this at district hospital? Can you build at least at 2 district hospital? Can we build some kind of fetal medicine? It's a struggle. It's not easy. None of the things that we have done is easy. But if some people are interested, can find time and energy, then things do change. I mean, what I try to show you is that in a very sort of decrepit system, you can also make positive changes. And it's not like the doctors are not interested. They are interested, but nobody went out to them and taught them in the right way.
Absolutely.
So yeah, I think with access and now technology getting more and more safer, so it needs to be properly used.
Here,
So
I would actually ask Sita ma'am and Dr. Kanchan.
No, Dr.
sir to-
Kanchan also, I will ask, I
Yes.
like Kanchan too, because he's the lead here. But seriously, as if we're just talking today, that we've started, especially Dr. Kanchan has started training the government sector doctors who come once a week, and with a lot of effort from, because it's a corporate hospital, get all these things done. So Kanchan has taken a major lead there. And now the doctors are actually, you can see the interest in them. Kanchan, can you come in and put in, because they were, that was the accessibility of training that was lacking. And now that they have it, they're going out of their way to go and get the training for doing these invasive
Yes.
techniques. Kanchan, please come in. Yeah.
Yeah, it has taken us a long time to convince the government officials that this is an acceptable model where the private players can also chip in and train their colleagues in the government sector. Now, I have personally worked for many years with a hematologist in prevention of thalassemia. I have been working with them as government hospitals actually unofficially send their thalassemia carrier parents to me. So I give them the sample at a very low cost. The patients then take the sample back to those two teaching hospitals, where they process the prenatal diagnosis. And there the facilities are available only to the extent of ARMS PCR. So they are only limited to 5 common mutations. Anyway, this has been running for last 11, 12 years, and we have been able to test about 8,000 women so far. But when I went to the government hospital at the government officials at the DHS level, of course, the awareness was still poor. Now, in the recent few months, when I started a full-time job in a corporate hospital, then I could convince my director of medical services that this can be done, and he has kindly accepted the idea. Then the government hospital doctors, they are so far the obstetricians have only come to us, and myself and Sita have been trying to train them as much as possible. Trying to teach somebody at an advanced skill while they do not have the basic and intermediate level skills in scanning. So it is not going to be easy. My idea was to train the radiologists more than the obstetricians. Maybe I'm trying to do a bit of a partiality here. But my idea was that they do FNSC day in and day out. So they have that hand-eye coordination. But so far, I have not been able to get hold of any interested radiologists, but I'm working on that. So one day, I believe that this will be disseminated to other hospitals, and I'm happy to reach out outside Kolkata and any other places. I just need the government backup. And I think we have started getting there. With this sickle cell program, when I heard Dr. Deepa that West Bengal is one of the focus areas among the 17 states, that has actually encouraged me to approach them again, that see, this is a national policy and there is a lot that we can do. Now, can I ask Dr. Deepa here that while working in West Bengal, I am experienced in seeing more of thalassemia cases, of course. Very rarely I get to do a PND for sickle cell disease. So can I tell the government officials that by actually attempting prenatal diagnosis for sickle cell disease, but by taking part in this, it can be a collateral benefit for us to prevent thalassemia as well. So that should encourage them more. Can I?
Yeah, definitely, sir, because two things, because sickle and thal also coexist. So that could be taken as a linker to say that we will take up this. And sickle depends on the severity, because when we offered, many of them have rejected, because it depends on, we have in Mysore a patient who is 81-year-old sickle cell, who is positive, who was never on hydroxyurea, had a normal pregnancy and detected at the age of 80 year during the national, during the screening. So a little challenges would exist depending on the clinical manifestation. Across India, it varies. Some places it's very severe, and some places it is a milder phenotype. So it would be definitely proposing it because it's there in the guidelines.
But the basic screening test is the HPLC, isn't it?
As per the national program, is screening is point of care as of now. If point of care is positive, then they are going to HPLC before initiating the
Sir,
treatment.
actually, the for sickle cell, it's the turbidity test, which is the main test that is differentiating, and after that only they are doing the HPLC. If
But
the
the
POC
guidelines
is
do recommend point of care. That's the first.
Yeah, point of care logistically as well as at the field level, like they are doing in Ayushman Arogya Mandir, that is Health and Wellness Center, and with so many programs, so they are loaded with so many national programs. It's very easy storing, conducting it, and the sensitivity of the latest. What the point of care test, earlier solubility was done. Now we have moved to POC testing, where lateral flow immunoassay has been used, which has a better sensitivity. Almost 90 plus is a sensitivity. So it would be easier if we take it from a public health perspective. So wherever there, we also train in such a way that if there is always an index of suspicion, confirm with HPLC.
So it is somebody is asking you, Deepa, can you just elaborate the POC test which you already said, but there is a question in the chat box. What is the test? So what is the point of care test by Dr. Chelapan? Can you please elaborate on that?
Yeah, point of care is at the place, at the periphery field itself. This has been, this was utilized. So 14 plus types of POC tests are available. So initially the sodium hypochlorite, the solution in that blood was put, and the solubility was done. And but it had a 60% or around that was a sensitivity. So now we came up with a better test, that is point of care test, which looks almost like similar to the urine pregnancy test kits. So where we open it, and the small buffer will be provided, a very small finger prick like we do for a random blood sugar, that much is sufficient, and very minimal expertise is also required to even perform the test as well as interpret the test. So they take 20 less than 20 microliter of the pipette it, and they put it into this buffer, shake it for 2 to 3 times, put it in the well, and wait for 3 minutes. So 5 drops is put into that. It depends on the company of the kit which the government is procuring. Different different states call for tenders, and whoever procures it, that is supplied. And today, as a mass screening, at a stretch they can do for 100, 200 numbers. The ease of it is, I can start and do in a camp mode also, covering a very large number of people. So whoever comes there positive, we will just explain them, saying that we have to recheck with another method. So because just by POC testing, like I had an instance where 2 of the sibling came as sickle cell positive in point of care test. When we did the parental testing, one was sickle positive, other came normal in the point of care. But we extend with HPLC, we got to know that the parent is a thal carrier, so sickle thal. So there are 2 instances, either paternity issues or something else. So we extended, we went to the extent where we did even the genetic test. It finally came to be the sickle thal only, but it depends on if SS percent, that is sickle cells are more than 50%, it always comes as SS. But parallelly there was A2 which was more. So which gave us an indication, recheck with finally. Some very rare cases we have to extend till the genetic testing. So we can't just stop at POC or stop at HPLC. Even HPLC has its own limitations depending on the person who does it and the instrument, biorad, or even now the capillary electrophoresis with Sebia, which gives a better eluting of other variants. So these all matters. So, but POC taking the mission mode, it's definitely useful, but it also
No,
has
because we have to have a cheaper test to screen. We cannot have an
So,
expensive
I have
test.
I have a question here. So once you do the POC, the HPLC is also offered free of cost, isn't it, everywhere?
It depends on the state, ma'am, because some of the states have made it mandatory for ANC, as somebody mentioned in the chat box, that any ANC HPLC is mandatory. But that doesn't exist in my state. None of the ANCs undergo, especially some of the corporate hospital offer it. Other than that, government setup, it doesn't. So Gujarat, Orissa, where this program in the state itself is running from years, this has been offered, but Tamil Nadu, none of the places this is given for ANC cases.
So I somehow feel Northeast is forgotten. Like, we are talking about all
definitely.
this, and Northeast is
Assam.
completely forgotten. So if I travel to the Northeast, and I do see a lot of HBE and S over there, so that they do have a high prevalence, and it's like completely forgotten, that part. So that's also there. I guess they also need to be integrated with the program, so that part is also there. Yes, ma'am, you were asking some questions.
No, I was just trying to say that because of the social mobility, or maybe, whatever kind of mobility we have across the globe these days. So these pockets that have been formed, like on the maps that we see in literature, have actually got blurred. So in a place like Delhi, and I come from a government setup, so we are offering HPLC as the primary mode of screening to just about every pregnant woman who's coming to us. And besides that, even ladies in the reproductive age group coming to us with refractory anemias also for various reasons are also being offered these kind of tests. And because of this mobility, Delhi per se is not a high risk area. We tend to discover a lot of thalassemia, at least, if not sickle cell anemia, in the course of a regular pregnancy. Thankfully, majority of them are beta cell traits, but yes, with eventually extensive screening of the partners also in the early first trimester itself, we have come to a lot of beta thal combinations and also sickle cell with beta thal combinations. I think pure sickle cell we have seen more rarely as compared to sickle beta thal, and that
Exactly.
eventually has a worse prognosis also. So which is why this
Exactly.
idea that Dr.
And
Dutta and me shared, that we should be looking at mutations, is very, very important, and calling it just a single gene disorder is no longer a valid idea.
yes, absolutely. And I would just move on to Gayatri Desai ma'am over here, Dr. Gayatri Desai ma'am, to see like her comments on, do you really see a lot of pure sickle cell disease, or do you see a lot of combination of these diseases also? Because Gujarat is
So
also
we
a
see
high
most of
zone for both, like beta thalassemia and sickle.
right, right. So most of our patients are SS. And I would say less, like around 2% we've seen sickle cell. And we do see a lot of alpha thal with her SS, but not much of sickle cell.
Ma'am, another question within the same family, do you see variability in severity? Because Dr. Deepa brought out a very interesting point that, that but there is ethnicity based, or there are some difference in the severity, even if we are looking at a sickle cell disease. So do you see like variability in severity in the same family?
We do. But typically siblings do follow kind of severity.
Same.
Like if one is very severe, the other it's unlikely to see that other person is totally normal. So, but there is variability within the family too.
There must be some modifiers also that is working, because it's interesting to note that there's alpha thalassemia. There must be some other
Yes.
modifiers which probably are working to maybe define the phenotype. So it's already 10:40. So
Yeah,
we and our though the we had about more than 100 people who had joined. At present it is dwindling, so we have to say goodbyes to everyone. So if there is any other question which is burning that we need to answer, otherwise we can call it off.
Madam, one sentence at the end. Like
Yes.
polio, दो बूंद जिंदगी की. So in sickle cell, one test the SPLC in a lifetime. So everyone, it is not according to the tribals or the anyone, any caste, creed, and any age. At least once in a lifetime, we have to do the SPLC test because of the now of the migration. It's not confined to the some of the caste. It's now whole world is being suffering from this hemoglobinopathy. So we should advocate our patient and population to screen at least once in the lifetime the SPLC test.
I have just one point to make if it is possible, time
Sure,
permits.
sure.
Yeah, from whatever I have learned during my course of fetal medicine practice, time bomb pregnancy is like a volcanic eruption waiting to erupt in terms of genetic disorders. And women often come to us having lost their previous child to a genetic disorder and saying, मुझे बोला गया था कि first जब pregnancy होगा उसमें CVS कर देंगे, knowing little that they don't have any awareness of the mutation that is involved in the first place. Because the obstetricians per se also do not understand the concept of a mutation. So what I am trying to suggest is that when women come to us, irrespective of whether they have a prior child affected or not, I normally tend to offer HPLC to both partners to conserve upon time, because once an HPLC comes back to me 3 to 4 weeks later as high risk for say thalassemia or sickle cell, now I test the partner, I lose the window of opportunity of a CVS. And offering a trio testing to those who are already aware of their partner status also goes a long way in terminating these pregnancies soon enough vis-a-vis a second trimester termination. So maybe offering HPLC to both the partners at the same time is the least we can do to offer a first trimester termination.
true. In fact,
Here, I would just have a small comment over here, and then maybe ma'am, please continue. But here, there's a small issue that comes up that whenever we are talking about thalassemia, there is intermedia also, and hydroxyurea is working well. So we also need to give an option, like termination of all pregnancies is probably not really how we should counsel, because if it is an intermediate, right now the statistics say the average age is 45 to 50 with treatment, and we have no right to say that that life cannot continue. So I believe that we need to be more careful, because now if there's more awareness, there's more diagnosis, and if there's more diagnosis, there is also more scope of error, because in pockets the knowledge is less. So that's why we should be very, very clear that we need to have people who are trained, and these people need to be more involved. Guidelines need to be there. There's already a guideline as far as thalassemia is concerned. We need to be more, we need to talk more about these guidelines to say which are intermediate, what can be counseled, and what can be the outcome. And it's obviously for the parents to choose. It's not ours to say to keep this pregnancy or to terminate the pregnancy. So whatever.
I would absolutely echo that sentiment. The entire idea of bringing up this was that I would personally consider each of us as facilitators to gain insight. So our job is to share the status of this baby or of the partners per se to the parents concerned, and then the ball is totally in their court. So to be able to give them that idea, that insight in a timely manner is what we require to do.
And also an informed
termination
decision.
is not just an option. Termination is totally in their court. I have seen Down syndrome babies being chosen
Yes,
to be
yes.
continued, and it
Yes.
is heartening to see that, because as I say, we are going pro fetus these days. Congratulations,
Ma'am,
Dr. Dipanjana. That was very well conducted.
Thank
Yeah,
you so much.
that's
Bengal
it.
chapter deserves a standing ovation and applause at least.
Thank you.
No, kudos to Dipanjana. Seriously, she's taken all the efforts. So thank you so much. In fact, we did a couple of we went to three health centers where we sort of made the doctors and the staff there aware of this. And that was also very heartening to know that they were not aware of these prenatal diagnostic techniques that was happening and what could be done, when it could be offered and stuff. So a lot of learning points in this sickle cell awareness month, I must say. Thank you all
And
for.
also, I think we deserve to applaud Gayatri ma'am. We
Yeah.
deserve to applaud Kanchan Mukherjee sir for what he is doing there in his part of the world. And we also tend to congratulate Ma'am Sita for having us all together.
No, thank you. Thank you. And right, so we say a formal goodbye and thanks to everyone on behalf of SFM Bengal chapter. Thank you so much for that.
Thank you, madam. Thank you all.
Thank you.
Thank you, madam. Thank you so much, madam.
Thank you, Preeti. Thank you.